Good morning, everyone. This is Cheryl Rucker-Whitaker. I'm the president of the Institute of Medicine and chairman of the Board of Governors. We're so pleased to have you join us today for our virtual convening where we explore the state of the health of Chicago. This is our grand convening. We did our kickoff on October 8th, where with the title, No Wealth, No Health, where we explored the structural barriers to overcoming barriers to solving social determinants of health. So today, next slide, please. This is our 8th convening of the State of the Health of Chicago. Next slide, please. About the Institute of Medicine, we are an independent organization of distinguished leaders in the health field who collaborate to improve the health of the public. Next slide. I want to thank our Board of Governors today. Without them and their leadership, today's event would not be possible. I want to give a shout out to all of them and thank them for their presence today and their diligence with me over the last 100 days. Next slide. So today's grand convening, our opening plenary, we have pleasure to welcome the Director of Public Health for the state of Illinois, Dr. Ngozi Ezike. Our next session will be on immunization strategy and COVID-19, where we will welcome Helene Gayle, who was co-chair of the National Academy of Medicine Task Force, a work group on putting together a plan for equitable distribution of the COVID-19 vaccine once it's available. Our next session will talk about the importance of integrated care in the COVID-19 environment. That'll be moderated by Raul Garza, Chief Executive Officer of Aunt Martha's Youth and Health Center. And then we'll spend time talking about maternal morbidity and mortality in the COVID-19 era and the challenge to managing worsening disparities. Our last session will be around the principles of well-being trust, where we'll welcome Commissioner of Public Health for the City of Chicago, Dr. Allison Awardi. And then we'll wrap up and have an after convening networking. We hope you can stay for all of the events. Invite your friends, come back for more. Please get your coffee. This is going to be a good morning to actually reconnect around topics that we in the healthcare field all care about. Next slide. Upcoming programs include November 10th, a fireside chat with Congresswoman Robin Kelly. This is post-election to talk about the legislative response and how disparately impacted communities recover. And this actually takes our conversation about social determinants of health to the legislative level, because we understand that many of these issues are structural. We'll need to understand what Congress will be doing, as we go forward into 2021. Next slide. Invited is Senator Dick Durbin to talk about healthcare the next 4 years, particularly around government-funded programs, Medicare, Medicaid, and the exchange, and talk about opportunities to innovate in the context that we're in. And we'll finish the year up with our virtual holiday event, where we'll do a 2020 year-end review. That event is scheduled for December 10th in the evening. Please put it on your calendar. Next slide. I want to thank our sponsors, for which the Institute of Medicine would not be able to do its great work. I want to thank our sole benefactor level sponsor, Blue Cross Blue Shield of Illinois. Thank you, Blue Cross Blue Shield of Illinois. Next slide. At our friend level, we want to thank the Rosalind Franklin University of Medicine and Science for their support. Thank you, Rosalind Franklin. Next slide. At our innovator level, we want to thank the Portis Foundation, the Washington Square Health Foundation, the Michael Reese Research and Education Foundation, the Michael Reese Health Trust, and the NextLevel Health Partners Managed Care MCO. Next slide. At the colleague level, we want to thank Care Advisors, Aunt Martha's Health and Wellness, and Golden Square. Thank you to all of our sponsors today. Next slide. So we are going to strive to stay on time today. You'll see that we have 2 10-minute breaks scheduled and 1 15-minute break scheduled. We intentionally schedule those breaks so that you can push back, check email, run errands, quick ones, etc., and come back to us. So please join us for all of the morning. We look forward to spending all of this time together. So, and then there'll be, if you could put your questions in the chat, we would appreciate that. And I'll be monitoring the chat along with Deborah. She'll let me know if there are questions and we'll do our best to get to those. You may say that we have short sort of time set up for each of these panels. I agree. We struggle with how to present some of these key issues. So we're gonna do our best to cover kind of highlights of these topics in the short time frame, but we want your suggestions for how we follow up. If we need to come back to some of the topics that we are talking about today, but we do understand that, you know, we want to respect your time. We know how it's hard to have tons and tons of screen time in one day, but we did want to try to cover what we saw as some of the key areas we were struggling with during the COVID-19 pandemic. There are some areas that aren't on this agenda, but we expect to follow up with those in the coming weeks, and we want you to lean in with your suggestions as well. Some of those things that we didn't get to are the opioid crisis. You know, we didn't get to kind of kids back to school, immunization, mental health. So there are a number of topics that we didn't get to, but we hope that, and we plan to over the coming year to come back to those topics. So want you to please weigh in as attendees to this event, also as members of the Institute of Medicine of Chicago. So we thank you so very much today for logging on with us. So we got great speakers lined up. Next slide, please. We're going to go into our opening plenary. I know that Dr. Ezike has joined us. I'm going to attempt to introduce her. She's had an extraordinary career. She is currently serving as the director of the Illinois Department of Public Health. Dr. Ezike is a board certified general internist and pediatrician. She joined the Illinois Department of Public Health from Cook County Health, where she served over 15 years, promoting Cook County's mission of delivering integrated care services with dignity and respect, regardless of a person's ability to pay. She's delivered inpatient care at Stroger. She served as a medical director of the Austin Health Center, located on the west side of Chicago. In her last role with Cook County, she served as medical director of the Cook County Juvenile Detention Center, which is the largest single-site juvenile detention facility in the country. Dr. Ezike graduated with honors from Harvard with a concentration in chemistry. Her medical degree is from University of California at San Diego, and she completed her internship and residency at the Rush University Medical Center, where she currently serves or has an appointment as an assistant professor of pediatrics. So today, I'm pleased to join Dr. Ezike for a conversation. This is less didactic, but a chance to catch up with our very busy State Director of Public Health. Let me find her picture on my screen. There she is. Hi, Dr. Ezike.
Good morning.
We're so happy to have you on today, and we thank you so much for spending time with the Institute of Medicine. We have over 120 people registered for today's session, so your word will get out. We plan to post our convening as much as we can on LinkedIn and other social media sites. So we're really excited to have you here today. How are you doing?
That's a tough one. Well, I had a birthday upon yesterday. I think I'm losing track of the date. The day before yesterday. And so I took a couple of hours to enjoy some cake and a Zoom call with my mother who shares my birthday. So that has brought some levity. Yeah, no, I'm hanging in there.
Well, look, no one, a global pandemic, just about a year into your service is something most public health directors read about. Yeah. When did you first realize that a pandemic was headed our way, Dr. Ezike?
So I think at the turn of the year, I was out of the country. And I remember seeing reports that first week in January about something happening in China, some infection, but definitely not thinking about that. I think it was several weeks later, when we were hearing more and more about this, and the CDC was actually, convening the state health officers and the leaders of the big cities to talk about this, to now talk about closing, down the airports and funneling them through certain major airports, of which, of course, O'Hare came onto that list. Then it started to become obviously real. January 24th was when we had our first case. And again, it was like, okay, an individual who returned from Wuhan, which we clearly understood was the epicenter. And then the next case was the spouse of the first. It's like that makes sense. And so the cases really just trickled in at first. So, no need to worry. We have 2 cases. For a whole month, we just had those 2 cases from the first. Then another one came in end of February. Oh, okay, that was from Italy. Italy was now a hot spot, but it quickly turned. I think by March 13th, we had 13 cases, but St. Patrick's Day, we had 55 cases and a death. And it was clear that this was not something that we just had in our grasp. And it just grew from there. And it's just been quite a journey.
Well, Dr. Ezike, March 13th, that's the date that NextLevel Health at our current company, we went all remote, like the day. So that March 13th will kind of go down in history for many of us, right? Because it was the day that kind of life changed for many of us, for at least 7 months and, probably another 7, right?
Unfortunately.
Talk a little bit about, as you mentioned these different landmarks, how are you assessing the capacity of the state to manage this response, and help us understand what type of capacity, do we have? Can you talk a little bit about capacity in the state of Illinois?
Yeah. So, first of all, not to just make excuses, but definitely, the health department had been losing funding, losing staff well in advance of this situation. So we were coming in, it was already an issue of, wow, we're short. Like, how many epidemiologists we have? We have about 30, where other health departments our size have well over 100. So those were issues we were already identifying and working to address, that we have to fill in these gaps for such a significant and large state. In terms of what we actually did have, sure, we had a pandemic influenza preparedness and response plan. We had the Crimson Contagion. That was the exercise, full level exercise that involved the feds, involved multiple state health departments, local health departments, all different state agencies and multiple partners. It was like a week-long exercise, again, focused around a flu pandemic that came out of China. But again, when people say, oh yeah, we've been through a pandemic, we've been through H1N1, it's kind of like saying, oh yeah, I've taken care of a dog, when you're now thinking about a Mastiff, but you've taken care of a teacup Yorkie, right? So the scale is so much greater. So I don't think any health department can be fully prepared for something like this, but I think everyone has obviously had these great individuals that have dedicated their lives to public health and have just really stretched themselves to capacities they didn't even know they had, to do all they could for the people of their state. And so I'm so proud to be at the helm, witnessing like this magnificent collaboration of efforts throughout the state.
So we talk a lot about the role of public health in managing a pandemic. What other agencies in our state are involved, just to help us understand the depth and breadth of collaboration that you're managing, or the governor's office and you are managing together?
No, that's a super question. It's definitely not just DPH, the Department of Public Health. We have been working so closely with so many state agencies. Of course, IEMA, the National Guard, DHS. They have lent us support both in people resources, not to mention all the support they have to give to the community that's dealing with the after effects of whether it's losing their job, needing mental health services, et cetera. Of course, we're working with ISB, the State Board of Education. We spent most of the summer together trying to think through plans of how we were going to do school safely, running tabletop exercises. Of course, our hospitals, every one of our 200 hospitals is a key player in this. And we've been working so closely directly with the hospitals, with the Illinois Hospital Association, our local health departments. That I should have started with them. They are the health department's right and left hand. They're the boots on the ground. They are making sure that the things that need to happen, happen. You can't say enough about the local health departments. When we talk about being understaffed at the state level, these local health departments, some of these departments are 4 people strong. And these are the 4 people that are, doing the contact tracing, identifying, cases, contacts, and of course, doing all the other things they're supposed to do around STIs and lead. So it's been a tremendous Herculean effort by the locals. And then of course, within the community, our community-based organizations, the Illinois Manufacturing Association, the Restaurant Association, our medical partners. I mean, the list is on. It's really an all-in Illinois approach.
Awesome. One of the things I thought we did a pretty good job of there's a lot of national rhetoric around testing and access to it, Director. But, I live on the south side of Chicago. I'm in 60649. It was a COVID hotspot for early on and for a while. But I was pleased as I was driving around our neighborhoods. I was on 95th over by DMV trying to get my 16-year-old her license, standing in line for like 5 hours. But there were free testing sites. I ran into a couple. And can you talk a little bit about, and I know places like Access. I remember when they rolled out a couple of free access sites over here on the south side of the city. But I know you had testing sites all around the state of Illinois that people could access. Can you talk a little bit about, what it took to roll that out, and just tell us a story or two about just getting that up and running?
Yeah. So luckily we're now at the phase where it feels like smooth sailing now. Now our issue is quality improvement and how to increase the throughput so that we can get, 1,000 cars through each day, which we are seeing. Initially it was, we don't even have the supply. It's like, how can we get the necessary PPE and the swabs and the viral transport media? But it really everything has been an evolution. But evolution, fast forwarded going, evolution is not supposed to be this fast, but it has had to be. It has had to be. And so going from, there was support from the federal government initially to start these community-based testing sites, the drive-in sites, which we now have 11 across the state. And so they started with support. The National Guard were key. They made those sites run just like clockwork. They had ample support. They were trained, kept things in order. When the National Guard had to step away to tend to other business, then we had to bring in private vendors. And so it's finding vendors, getting them trained. Again, this is not something like, oh, we've been doing this business for 3 years. We're happy to come in and do nasal swabs and get it to the lab. So just all of that, just trying to get it, plan, do, study, act, repeat, get it better. That has just been constant, but it's so amazing to look back on such a short time to see where we've come. But that wasn't enough, right? 11 sites around the state doesn't cover everyone. We had to engage, hospital partners, make sure that they're ramping up their capacity. We were giving machines to other facilities to say, please start testing. We had to give FQHCs the ability, because we want to make sure, harder to reach communities also have the opportunity to get tested. And then we had our WOW mobiles. We have these massive, health mobiles that can get into the even harder to reach places. That van has been going to migrant farm workers at their job site and at their living site to be able to do testing and give education about this. So it's just been, such an incredible, when you look back, it looks tremendous. We're the 3rd largest testing state of all the states, just behind California and New York. But, going from having 0 of these tests in February to now doing 70,000 tests a day, something to be really proud of here in Illinois.
I think the the communication strategy that you put in place, I think is, uh, I think it's been working. You early on, you asked health professionals, and I think anyone who wanted to sign up for Siren. And I get those every morning or afternoon, and I'm very
All
appreciative.
right.
Yeah, very
A lot.
appreciative. I know it takes a lot of work, I'm sure, to push out factual information like that, updated every single day. So I want to just thank that team that you have working on that for doing that.
Yeah, they're amazing. You worry because, is there such a thing as too much information? But there's so much happening. There's so much changing that, if people can keep up with that, then they'll be on top of that if they can follow those siren notifications.
So can you comment, Director, on the current surges that we're seeing in Illinois? We've been talking about this and forecasting it for a while. We're saying, hey, we're going to go into cooler weather. There's virus fatigue. People are tired of the virus, but we know the virus isn't tired of us, right? So talk a little bit about the current surges you're seeing, and what do you think some of the reasons are? And, what do you think, what sort of strategies are going to make sense for us? And remember, we all have to stay sane as well. So talk a little bit in the context of like sanity here. Many of us are parents, we're grandparents. I know Mark Shields, one of our board members, he has to homeschool his grandkids so his children can go to work. So there's a lot, as you know, moving on. And like I said, today's convening, there's many topics we'd love to cover, but we can't cover them all. But that's certainly one of the things that's on the mind of many of us. So kind of how this is going to play out during the winter. And then at the end, what do we need to do? Like, how do we help you? So that was a huge, long, rambling question. Okay. The question is, can you comment on the current surges that you're seeing in Illinois? And then talk a little bit about what you see as the reasons, and then how do we as a collective community kind of work together to kind of manage this?
No, that's the $1 million question, and absolutely what we are, spending all of our time thinking, deliberating, praying about. The second wave is here. The second wave is here in every single region. We divided the state into these 11 regions of the state. Before, we were looking in the 4 regions. We broke it out to 11. Every single region is increasing their positivity, is increasing the number of individuals that are going into the hospital. Some decrease in hospital capacity, that's in certain areas. We are in the second wave. The cases are increasing. We know that the 20 to 30 age group, they're the main drivers now. They have the most number of cases, the highest case rates and case counts. But as we've learned a lot about this virus, where we know that those individuals are least likely to get significantly ill and or perish, but that doesn't stop them from spreading it to others. And so we are seeing, as people have been fatigued, as you said, or just over the virus. I'm done with it. Got to get on with my life. I've already missed the birthday, the wedding, this graduation, all these things have been canceled, and people are like, not going to keep having things canceled. And so people, you do a little bit, have a gathering, nothing happens, then you let your guard down a little bit more. Then people are just having, full on, pretend there's no COVID and just moving about. And so that's why this is spreading. And we're not even fully into the stage where everybody's indoors. We're still trying to hang on to be outdoors. Yesterday felt almost balmy, but yeah. I am super concerned that as we really do go indoors, have the first frost, Thanksgiving, that's what's giving me palpitations. That will not, we talked about super spreaders. We've talked about super spreading event. Thanksgiving has the potential to be the super spreader attending a super spreading event that is week long, right? Because people do their Thanksgiving, some people have the whole week off. People have Wednesday, Thursday, Friday, Saturday, Sunday. And this is going to be congregations of people from different households, all ages, different risk groups, that are going to be feeling comfortable and happy to finally be with their family and friends, letting their guards down, eating, drinking without masks. And it just scares me, the number of people that will be there at Thanksgiving and won't be there at Christmas. And if we don't get the message out about, as unnatural as it feels, as much as we want to be in denial, that we have to, in our own homes, be wearing masks around family members that share our last name, that are loved ones, but are not really in our households, that we have to accept that we don't know who has the virus. That asymptomatic spread is really what is getting us. And so if we can't wear our masks all the time, that we are going to, this peak, the peak of this wave will be worse than the first, remembering that the first wave primarily centered around our urban centers. Chicago and the surrounding suburbs was mostly hit. Now we have every rural community, every part of the state is involved in this. So this really has the potential to just be something well worse than what we saw in that first wave. So that's not great news, but the good news is that we do have control. If we do take to distancing and masking, even in our own home, we can dampen this. And so I'm imploring you to get that message out to all of the people that is our only way out in the absence of a vaccine or a surefire cure at this time.
So Dr. Ezike, I just wanted, for those who are less medical, you said, well, 20 to 30-year-olds are spreading it, but they don't really get sick. But what is that marker that you're looking at that makes you sort of stay up at night? It's the case counts make you anxious because there's a percent of those people that are going to die. And in between there's a percent of those people that are going to end up in the hospital. So talk a little bit of just about that, for just to ground that real quick. You don't have to go in deep, but just ground those, connect those two for folks.
Yeah. So deaths just don't happen out of a vacuum. Before the deaths come, as you already eloquently said, people usually were in a hospital. Medical teams were fighting to get that person better. Before you got into the hospital, of course, you got sick. Before you got sick, you got infected. So the number of cases that we report each day, which is numbering, 2,000, 3,000, 4,000 each day, from cases, again, not everybody will go on to be hospitalized, but we know that the higher the percentage of cases, the higher the number of hospitalizations that we'll see about, a week or two later. And we know, of course, not everybody dies. We actually have much better treatments, much better, not necessarily like a surefire cure in terms of a single pill, but we have different treatment modalities. We know about using steroids. We know about proning, how to avoid maybe using the ventilator. We used to put everybody on the ventilator when you had severe respiratory disease. This virus says, no, if you put me on the ventilator, that's the bad route. And so, there are other ways that you can try to get oxygen in the lungs, which literally involves our, tried and true respiratory therapists, putting people on their stomach, flipping them on their side, just different ways to aerate the lung, which is something that we really haven't used, that a lot of people have never heard of proning until this virus. So, again, the more cases now means that there are going to be more deaths. So even if we don't we do see the deaths. Unfortunately, for the last 5 weeks in a row, the death numbers, weekly totals have increased, which fits with the increase of cases that we have been seeing.
So, Director, I'm going to pivot for a minute, which I know that you probably don't get many people that ask you this question, but can you tell us what are the other priorities of the department outside of COVID-19?
I know, right?
And talk a little bit about what else is IDPH working on, monitoring, any other conditions, facilities, the things that you monitor, support, any other important priorities for you. Tell us a little bit about that.
No, that's so important. Like, nothing else gets to stop. We don't get to stop doing all the newborn screening, lab testing for all the kids that are born every day in Illinois. I heard you mention maternal mortality. We are having, we follow up on all the cases of women who have died within a year of being pregnant. We have a report that we put out. We're working on how to decrease those numbers. We know that there's huge disparities that we're working on. birthing hospitals closing does not help with the issues around maternal mortality and access. You know, before, when I first came into the agency, I said we were going to tackle, you know, racism and health equity. And clearly COVID has just demonstrated, you know, the issues around that and how important it is. You know, the other, you know, protest movements also, you know, in highlighting all the needs. Legionella is actually kind of directly tied to COVID because we've had all these buildings and facilities that turned everything off, you know, for weeks, sometimes months. And so, you know, just being cautious and aware that all those water systems that were not in use, you know, Legionella was just sitting there harboring, festering, you know, and so just being on the lookout for that. And then of course there's lead poisoning and trying to go into the homes to identify lead sources. So none of that important work gets to stop. There's so many programs that public health has already been stretched to be doing, and COVID has just been on top of it. But yes, that work continues. And don't forget Getting to Zero. We launched Getting to Zero. We wanted to wipe out HIV, AIDS, you know, over the next 10 years. So there's a lot of work to be done.
So our next session after this is going to talk about Dr. Gayle, who co-chaired the National Academy of Medicine work group on equitable distribution of the COVID-19 vaccine, when and should it come online. We'll be talking, and then Donna Thompson from Access Community Health Network, our state's largest FQHC, and Samantha Olds-Frey from the Illinois Association of Medicaid Health Plans will be on talking about the challenges they've seen on the ground to just our current immunization, kind of where we are with the routine ones, and then sort of sort of just talking about and opining on what our challenges will be as we come to COVID-19 vaccine distribution. I know that the governor on Wednesday, I believe it was, you're putting together your state's program on this. And can you kind of talk us through your thinking there? First, start with, let's break it up into a couple of spots. One, you know, what are your thoughts and concerns? You know, you're a pediatrician. One of your hats is a pediatrician, with the decreased routine immunization that we've seen because of folks staying away from the healthcare system.
Yeah. So we, of course, you know, part of it was recommended that everyone stay home. You know, we had to take that initial time out, the stay at home. I heard it better said by the health officer in Kentucky. They called it healthy at home. Sounds a little bit nicer, but you know, people stayed home. We didn't know what we were exactly dealing with this virus, it being so new. So people were reluctant, hesitant to leave their homes, even for their well child checks. And that was appropriate, I think, you know, and so consequently the vaccination rates did go down. I do hear now from pediatricians that people are coming back. You know, we've had the tincture of time. We've had the ability for the health clinics, you know, the medical clinics, to know how to bring people in safely, you know, the masking, the signs for distancing, keeping, you know, waiting room capacity low, not having large crowds. So all those things that we've taken time to understand and implement has made going to the doctor, seeking care safe. And so, you know, we're promoting that. And I think people are going back, are starting to go back, but we do need to catch up on those visits that were missed, on those immunizations that were missed. And I'm, you know, we're working with, you know, the Illinois chapter of the American Academy of Pediatrics and the family physicians and all the people who care for our kids to make sure we keep hitting that message that it is safe to go to the doctor. We don't want to create, you know, a measles epidemic because everyone is now missing those, you know, those primary vaccinations.
Great. Now, as we move to the COVID-19 piece, can you talk a little about the draft? I guess we actually went to your website and we pulled it up and we sent it out to our members. It's labeled draft right now, it seems. Yeah. But talk a little bit about your thinking around the COVID-19 planning. Tell us what you guys are doing, and kind of bring us up to speed on the Illinois response.
Yeah, so we have been working with, you know, with the White House task force, with the CDC, with HHS, with FEMA, all, they get us on calls with all the other health departments. Some of Chicago has a part of this as well. Some of the big cities have their own role. And so we've all been collaborating, talking through, what this mass vaccination plan should look like. Again, Illinois, I feel comfortable to brag, was well ahead in terms of, planning some of this out, but of course, understanding that there are still so many unknowns. We don't even know for sure which vaccine will be utilized. And so that means, if you're going to have a refrigerated vaccine versus one that's frozen versus one that's ultra cold, so some of those logistics you can't, we're just kind of planning for all things, having contingency plans because a lot of uncertainty. We know that there are probably going to be 2 doses instead of 1 dose. But the main issue, and I know what everybody's very concerned about, is like, who's going to get it? We don't know when it's coming out. And we don't know the exact amount that will come out in that first allocation. We know that it's going to take a while for full manufacturing to come up. So there are these phases, if you will, in terms of who will be receiving it. And so spending a lot of time on making sure that the right that the priority groups get it first when there's limited allocation and then moving forward. So in that phase 1, it's actually divided into phase 1A and phase 1B, where there would be healthcare workers, right? Healthcare workers will start and first responders. That's the highest priority group, 1A. And then 1B are the individuals who the highest risk of succumbing to the virus. So people with comorbidities that portend a super, super high risk. And then, of course, we know that we saw the devastation that occurred initially in the congregate care settings. That's a very vulnerable population. So the congregate care settings are also in that first tier, that tier 1, 1B. Then you would move to the second level where the educators, our teachers, our daycare workers, getting all of them immunized, as well as other critical infrastructure workers are in that second tier. We have to remember how significant spread is in jails and prisons. So that actually rises to the list. Homeless shelters, that's also in that phase 2. So we have a lot of groups that need special attention. And then of course you have to pay attention to the communities that have already been the hardest hit and that are likely to be hit again as we go into the second wave. So making sure that there's equity with regards to that, using the CDC's Social Vulnerability Index tool that basically tells you before any kind of disaster hits, which communities, which areas, which zip codes are most likely to bear the brunt and take it the hardest, and then trying to reach into those. So we're hoping, as people are signing up to take on this task of vaccinating people, that at the state level, we'll be looking at the zip codes of individuals, that have been vaccinated. We're hoping to get information on what high risk category to make sure that we're getting those priority people, and then can redirect vaccine as additional supplies come in to those priority groups. But again, it's not a matter of just having the vaccine. You have to make sure that there's a population that wants to take it. And so we're doing some of the groundwork now to educate people about vaccines in general, the process of vaccines becoming authorized, how this vaccine will be authorized, what we will know and what we will not know, just giving them all the tools so that we can overcome some of the mistrust, the misunderstanding, the myths that might be out there.
Yeah, I was going to ask you that, and we have about 4 minutes left. If there are any questions folks have, please send them in the chat. Director, you mentioned the nursing homes, and I know that you regulate nursing homes. They had a particularly tough time, particularly when younger people who work in and out of those places were moving in and out, asymptomatic probably, and sort of moving the virus around. How have it? I know that you've gotten it managed. You want to give us just a quick update on how the nursing homes are doing, how our grandmothers and great grandmothers and parents are doing?
No, that's an important point. They really bore the brunt of this at the beginning. where up to 50–60% of the deaths were coming from long-term care residents. I will say that as we've had this surge and the second wave coming and more cases, they are not driven by the long-term care facilities. We've actually had decreasing numbers of deaths in the long-term care population as the outside the long-term care population deaths are growing. And even as you look at the individuals, I took a list of the people over 80 that are succumbing to this virus, over 70. They are people who are getting it from those younger people out in the community. It's not the people in the long-term care facility. So we've really turned that around with massive testing. There's like regular testing, weekly testing until you have no more positives in staff and residents. So some emergency rules and has helped us get to that point, and a lot of partnership with the long-term care facilities and the stakeholders.
So we have time for one more question. There's a comment that outbreaks are still occurring in nursing homes. So you kind of answered what you're doing to mitigate that. There's I guess some recent guidance has been a little bit confusing around how many people can gather where. And one of the questions was around, can we get a coordinated response? Because it's confusing that that we're changing the number of people that can gather at one time. It says now, are they saying no more than 6, or is that a Chicago thing, or is that an Illinois thing?
Yeah, no, that's a great question. So, we did the statewide approach when we did the quote healthy at home, and people, clamored that, well, it's not really an issue everywhere. You should be a little bit more targeted. So as we go into mitigation, when we have certain areas of those 11 that we've now divided the state into 11 portions, if a certain region, one of those 11 regions now gets over 8% positivity, again, remembering just, 2-3 months ago, we were looking at 2%, 3%, 4%, but when they get to 8%, then we put statewide mitigations there. And then we'll say like that the gathering size, at a restaurant has to be smaller, instead of 50, which is generally for the state, that region might be 25. We have some regions that have gone past the, 25 that we've had to say now 10 because they've continued to have increased cases and increased positivity. So maybe if people don't understand the different regions and maybe their region has gone into a mitigation, and so additional strategies have been implemented there. But we were trying to do a scalpel approach instead of the machete approach and deal with, region by region.
Director, are the nursing homes getting enough their share of PPE?
Right. So that was a big issue at the beginning. There was just a worldwide global shortage of PPE, as the main manufacturers were the Chinese. And so they were battling this pandemic. And then when they started, manufacturing, they were keeping it because they had such an issue. But those supply chains are much better now. We're actually working on building up a better stockpile to make sure for the peak of this second wave that we'll have enough. The local health departments are responsible for getting PPE to the nursing homes, and we have not been able to not fill it. We have been able to fulfill all requests. So I don't think that shortage issue is applicable now.
So I think that there's a couple of things coming on the chat, that there's still nursing homes that are having challenges getting PPE, and maybe there's a group purchasing initiative that might make sense. But here's what I'm going to do. Director, if people feel like if they know of nursing homes that are having a challenge, I'm going to ask them to send me an email, send me a text, because I'm going to write down and I'm going to send you a note and say, here are the places that folks have said, because one of the things we want to do is just be sort of proactive and constructive. So we're just going to and we want to give you sort of data, right? So we say, well, people say I'm having trouble. Okay, well, tell me the 3 that still have trouble, and I'm going to send you those, right?
That's great.
Because I think that's how we kind of solve this. I feel like just going straight at it and trying to just be really constructive and get something done. It's really tough managing in a global pandemic, and honestly, none of us saw this coming, really. So I think there's an opportunity for us to all really work together. You got some great folks on the phone who who are very engaged. And apparently the nursing homes report their shortages in a public database that they're required to report to CMS HHS every week. So I'm assuming, Director, you guys are monitoring those reports?
So we are working closely with CMS. We have eyes on. We work with CMS. We're an extension of CMS. I think some of the understanding needs to be that we were in the midst of a horrible situation, new novel situation, and so we were just giving out PPE to everyone. So as we have come out of this, and as the federal government has made millions of dollars also available directly to the nursing homes, they're also partnering in this need to to secure what they need to get also. So we try to put everything out, but we're working to get to a spot where they're also procuring the supplies that they need and that we would be back up. So we're trying to see how to strike that balance. Again, it's easier to say someone give it all to me versus trying to figure out how people are going to procure that on their own, given that they are private for-profit entities in many cases.
So, Director, this has been phenomenal. I love just being able to have a conversation with you, relieve the stress on just preparing slides, because it's just great to have you just talk to us. You got so much that you can share, and we could talk for hours. So we want to thank you. The chat is active here. We're going to continue to monitor it and try to capture any comments we didn't ask you about and circle back with you through your staff. But we really want to thank you, and you're welcome to stay on for the rest of the presentation. I think Dr. Gayle's gonna come up next after Dr. Sandlow introduces her. So thank you so much for being on with us today. We really appreciate you.
Thank you so much for having me. Hi, Dr. Gayle.
Because I know she's going to run off and leave. I just want to say hi and thank you again for everything you're doing.
Thank you. So good to see you.
Yeah, good to see you.
All right.
All right. So Dr. Sandlow, if you could come up to the mic. Dr. Sandlow is on the board of the Institute of Medicine of Chicago. He is an emeritus professor of medicine at the University of Illinois at Chicago, and he's on the board of the Portis Foundation. The Portis Foundation is a sponsor for this upcoming session on immunizations in the time of COVID-19. Dr. Sandlow, you there?
I'm here.
Wonderful.
Good morning. Welcome to this conference, which so far has been really fascinating, and I'm sure the rest of the day will be. The session is immunization strategy and COVID-19. What do we know? You already know who I am. I just want to mention that Portis Foundation is sponsoring this to a great extent because it fits exactly into our mission, which is in the support of research, innovation, and education in health promotion and disease prevention. And what fits better than immunization? It's my pleasure to introduce the outstanding panel that you see in front of you now. Cheryl Rucker-Whitaker.
Just say Cheryl. Just say Cheryl.
It,
Hey, let's skip. Everyone knows me. Skip mine. You're good.
Anyway, she's already introduced. She's the CEO of NextLevel Health and the president at this time of the Institute of Medicine of Chicago. She's a physician, healthcare executive, and entrepreneur. And in 2014, she co-founded the NextLevel Health, a groundbreaking insurance company, which is really dedicated to helping Cook County underserved access and manage the whole issue of Medicaid services. In 2020, this current year, she was recognized by Cranes as one of the notable women executives. The next of our panel includes Helene Gayle, the president and CEO of the Chicago Community Trust. She's a pediatrician as well as a public health physician who spent really 20 years or more of her life with the Centers for Disease Control, working on HIV, AIDS, and disease prevention. She also led the Bill and Melinda Gates Foundation program on HIV, AIDS, and some other global health issues. So, and then for the past decade, almost, she's been the president and CEO of CARE.
Samantha Olds-Frey. Sam is the Chief Executive Officer of the Illinois Association of Medicaid Health Plans, which represents all of the health plans currently serving the Illinois Medicaid managed care market. Thank you so much, Sam, for joining us today. And then Donna Thompson. Donna is a registered nurse by training, and she's the CEO of Access Community Health Network, our state's largest federally qualified health center, and was really on the front lines when the state asked FQHCs to join in with supporting the testing rollout. But they take care of hundreds of thousands of people across our state as an FQHC, and will be on the front lines of any vaccine distribution. So thank you all for joining. And we're going to jump right in. Dr. Gayle, you're going to walk us through, you co-chaired the work group for the National Academy of Medicine on equitable distribution of the COVID-19 vaccine. So you're going to take us through those recommendations. We know you have to leave shortly, but walk us through, stay as long as you can. And we look forward to having you update us on that report.
Great. Thanks so much, Cheryl. And sorry that I won't be able to be here for most of this, but it's hard for me to say no to Cheryl, and so I carved out a few minutes to be able to do this. I think we had some slides. Yeah. So as Cheryl mentioned, this was a study that was done with the National Academies of Science, Engineering, and Medicine, along with the Academy of Medicine. As people, I'm sure here know, the Academy of Medicine is what the Institute of Medicine used to be, and now it is merged within the National Academies of Engineering and Science as well. And we can go to the next slide. These studies that are done by the National Academies generally have a study sponsor, oftentimes a government agency. And our study sponsors were CDC and the National Institutes of Health. And I think they asked for this study to be a fast track study, given how fast the development of vaccines were going. And I think they also did it with the hope that the independence of the National Academies would be helpful at a time where there's been so much confusion, lack of transparency initially, et cetera, around the vaccine development. And so we were asked to do this study on at the request of these two agencies. The next slide. Study committee, I was very fortunate to have as my co-chair, the Bill Foege, former CDC director, also one of the co-leads of the effort to eradicate smallpox globally, a real public health legend. As you can see, we had a committee, a broad-based committee, about 18 people, bioethicists, statisticians, public health physicians, epidemiologists, immunologists, gerontologists, et cetera. A really rich group of people to pull this study together. We had about 2.5 months. Anybody who's been involved in some of these studies know that they are usually a year to 18 months. So this was a really fast track study with a lot of information to take into consideration and pull together. Next. The overarching charge was to develop an overarching framework for vaccine allocation to assist policymakers in the domestic as well as global communities about what does it take to have an equitable allocation of the COVID-19 vaccine, with the hope that this will inform decision makers and national health authorities, including the ACIP. And the ACIP, Advisory Committee on Immunization Practices, is CDC's standing body that recommends on the distribution and implementation of vaccine programs. So it was envisioned that this would be an overarching framework that others could then take and develop further. Next slide. We had to take into consideration some of the specific aspects of this pandemic and of this particular virus and its evolution. So, one of the things that we felt was very important to take into consideration was the disproportionate impact on racial and ethnic groups. We did this by looking at some of the increased risk in communities that were really linked to social and structural inequality. So disproportionate representation in high risk jobs, disproportionate comorbidities that lead to serious outcomes if somebody is infected with SARS-CoV-2, et cetera. So really wanted to look at what were some of the increased risk factors. And then obviously we know that advanced age along with comorbidities are other important aspects to this pandemic. So those were some of the things that, were highlights of this particular pandemic that we thought was important to take into consideration as we looked at our framework. And as we looked at in the next slide, kind of some of our overarching issues. This just gives the vaccine landscape. As everybody knows, there's a lot of candidates out there. Many of them are still in the preclinical development stages. And they're now over 38, but close to 40 being tested in clinical trials. We know here in the United States, so that's the global picture. In the United States, we have U.S. Operation Warp Speed that has a portfolio of 6 candidates, and 4 of those now in phase 3 trials. Importantly, we know that these phase 3 trials too will have a new platform, the mRNA platform. Others are using things that have been used before, replication defective vector vaccines. So we have both a new vaccine being developed, but also a new platform and vector, and one that has particular requirements, and that I think will play into some of the aspects around the distribution. We went into this both without an actual vaccine, as well as a lot of unknowns that would affect the allocation of vaccines. So, in some of the vaccines, they are 2-dose vaccines. So where others will be developed, it will probably be 1 dose. So the timing and the number of vaccines, and even the availability of vaccine doses, we don't know how many will be available by when. We still don't know what the efficacy is. While there is clearly more and more safety data being collected, there's, because of the speed and the time that the vaccines are being developed, we won't have the safety profiles that we often do when we start allocating vaccines. Vaccine uptake, there's been a lot written, there's been a lot talked about around people's hesitancy around taking this vaccine because of the speed of the development, because of some of the politicization of the vaccine, et cetera. So there's a lot of concern and a lot of unknown about vaccine uptake, even once it's available, the number of available vaccines. With so many vaccines being developed at one time, we don't know how many will actually be out and ready and circulating at any given point in time, et cetera. What are the epidemiologic conditions? Will we be in an upswing? Will we be in a stable state? Will we be in a declining state of transmission? So many unknowns were part of this, and we tried to do scenarios to think about what would be, how would it impact our vaccine allocation given some of these unknowns and uncertainties. So pulling all of that together, I'll get to our framework, and at the bottom there, we wanted to have some important foundational principles because we wanted to make sure that this was grounded in both ethical principles as well as procedural principles. And the ones that we thought fit this particular pandemic the most as far as the ethical principles were, one, maximum benefit. How could we make sure that this allocation had the most benefit for the most people? Equal concern, all lives being equal and not judging whether one profession or one circumstance was more important than the other, and that the mitigation of health inequities was critically important, particularly given the disproportionate impact on communities of color, and certain procedural principles that we followed in our allocation. Fairness, transparency, and transparency being a big one, again, because of some of the concerns about vaccine hesitancy, and then evidence-based, making sure that we were leading with the science and not with politics or others. So we came up with this allocation framework with the goal of reducing severe morbidity and mortality and negative societal impact due to the transmission of SARS-CoV-2. And we used a risk framework for our allocation criteria. So the risk of either acquiring and by extension also transmitting infection, the risk of severe morbidity and mortality. And again, as we know, there's been such huge societal impact. We also thought the risk of negative societal impact by somebody getting the virus or getting the mortality or morbidity was important as well, and came up with the 4 allocation phases in the next slide. So, and I won't go through these in total detail, but just to kind of give you the general thinking, with those risk criteria, acquisition, severe morbidity, mortality, negative consequence, and then risk of transmission, we looked at this in terms of how those apply to different populations. And we used phases as opposed to tiers. Oftentimes you'll see vaccine allocation frameworks have tiers, which are more static and often say that there's groups that should have it kind of consistently more than other groups, oftentimes with age cutoff. Here we felt that once a vaccine was available and once there was enough vaccine, everyone should have access to the vaccine, but we know at the beginning there's going to be scarcity. Therefore, we had to look at who should get it first and then, kind of roll out after that. Not surprisingly, in the very first phase, we have high risk health workers, both because they're at high risk of acquiring, potentially of transmitting, and because of the impact on society if healthcare workers are not available. We also said the same for first responders, and we didn't put like EMTs, et cetera. In our healthcare workers, we didn't say physicians first. We said anybody, and this is really based on who was at most risk because of most contact. This would include nursing home, health home care workers, et cetera. Anybody who was at high risk of contact and who also would have a negative societal impact if they were not able to take care of people with illness. We have then looked at, and we put a jump start because again, we know that there may be very, very limited amount of vaccine in the very beginning, and because the candidates that are further up the line are ones that may not be able to be distributed through the normal kind of decentralized way in which vaccines are available, and that they may need to be done in a more centralized way, particularly for the vaccines that require very, very stringent temperature controls. Also in that first phase, we had people of any age who had one of the very most severe comorbidities that put you at the highest risk of severe disease or dying, and then older people living in congregate or overcrowded settings. We then kind of went down that risk allocation framework that we had. And, as an example, in phase 2, we have teachers, K through 12, critical workers in other high-risk settings, people living in congregate settings like homeless shelters, prisons, jails, detention settings, and then all older adults, 65 or so older and older. Third phase, young adults, children, with the caveat that children have not been part of the first phase of clinical trials, so we'll need to make sure we have the right clinical trials data to be able to see whether or not children should be part of that phase. Hopefully by then we'll have enough information about children and then workers in the industries that are important but don't have some of the key societal impacts as in the first 1 or 2 phases. And then we say in phase 4 that everyone residing in the United States, regardless of legal status, so anyone living in the United States should have access to the vaccine. Because equity was such an important part of our consideration, we had as a cross-cutting issue that in each of these phases, vaccines should be prioritized for geographic areas identified with CDC's social vulnerability scale or some other specific index that looked at the social determinants of health and the risk factors that put communities, and particularly communities of color, at highest risk. You can skip 2 slides forward. Next. So just quickly, summary of our recommendations. First and foremost, we recommend that this framework be adopted and that policymakers take into consideration this framework as a basis for allocation. That we leverage and expand the use of existing systems. There's been a lot of discussion about having alternative ways of distributing and allocating the vaccine. We know that there is a strong tradition of national vaccine programs with CDC leading and providing guidance to state, territorial, local, and health authorities. We feel that's the system that should be built on and not creating parallel systems just because this is a different situation, that we will be much more well served if we use the channels that have worked well. We thought that cost considerations were incredibly important. Billions of dollars have gone into making this vaccine, such that cost should not be a barrier and that nobody should have to bear out-of-pocket costs, not only for the vaccine, which people have already pledged to provide free, but also for the administration of the vaccine. The next 3 really relate to this issue of vaccine hesitancy. And we really felt it was important to have multiple recommendations. First, one around developing programs on risk communication, so people actually understand the risks and the benefits in a transparent way, that there be community engagement as part of this so that communities are hearing this from institutions and organizations that they trust, that there be at a national level a vaccine promotion campaign. So again, that people are hearing this in a consistent fashion, and that in the process that we develop an evidence base for what the most effective strategies are for promotion and acceptance of this vaccine. And then finally, we made a recommendation about global allocation. We were asked to do so as part of our charge, but we also felt a real obligation that at a time when we have been withdrawing from the global collaboration around vaccine, at a time when we're saying we should back away from the World Health Organization and not be a part of COVAX, which is the global COVID vaccine facility, that this is the time to affirm our commitment to the global world and to be part of this global effort, because it's the right thing to do. We've always had a leadership role as a global, as the United States in global health, but it also is the right thing, the smart thing to do. We are not an island, and if we're not engaged in the global world, we can't expect that we're going to keep our citizens safe while we're not engaging globally and making sure that everybody is safe and that we all are looking at this in a collaborative way. So I will just stop there. I think I've just about taken time. I don't know if you want to take 1 or 2 questions or we turn it over to the panel.
Dr. Gayle, right now, we don't have any questions in the chat. So
Okay.
I want to thank you for helping to set the stage here. You followed up on Dr. Ezike's kind of comments around Illinois, helped us with the national framework that's being proposed. So really appreciate you coming. We're going to ask Samantha and Donna to come up now, and we're going to kind of walk through a series of questions.
Thank you.
Really about our ground level strategy. So thank you so much, Dr. Gayle. So thank you so much. I think Samantha and Donna, I see you. Hold on one second here.
Good morning. Can you hear me?
Hey there. Yeah, so we learned a bit from scheduling this program, guys, that we needed a webinar program and not a Zoom call program. So I don't have you both on the same page. So I apologize for that. But what we do have on the presenter screen is a picture of all of us, right? So folks don't get whiplash from flipping back and forth to find us. So Sam, I see you. Donna, I see you. Thank you guys so.
Cheryl, you're on mute. Oh.
Okay. Wow. Okay. Someone wants me to stop talking. So Donna, you were here from the beginning. You heard Dr. Ezike talk a little bit about the current immunization challenge, given the last 7 months and the events associated with that. You heard about the upcoming COVID-19 vaccine, and unless you live in a bubble, you can't help but hear all the kind of the politicization, if you will, of this vaccine, and nothing quite like, I mean, you've been in healthcare, quite some time here, nothing probably like you've heard in your lifetime. So if you put all that together with the work you do every day, so I'm asking you kind of a loaded question because I want you to just start out. Why don't you just kind of opine on your thoughts from what you've heard, but what you see every day. I heard when you guys rolled out your testing site, there you go again on the front lines of bringing testing to a vulnerable community. So clearly you understand the communities that, when Helene was talking about kind of zip coding and taking a look at this COVID sort of vulnerability index, that meant something to you. Why don't you kind of give some opening remarks there around your kind of thoughts in response to kind of what you've heard so far and, informed by your work to this point.
Absolutely. Well, thanks so much, Dr. Gayle, for your remarks, and also Dr. Whitaker. Access is in 16 of the 20 most under-resourced communities in the Chicagoland area. And when we thought about how we would set up COVID, a lot of the learnings, as we've said, as we've gone along, and how we, every week we're learning something different. But early on, it was important for us to think through not just about COVID testing, how to get our patients or people engaged in their health because of the disparities, but also we knew that if it would go into the long winter months, how could we keep the momentum going? And so we set up 5 COVID sites at Melrose Park, Auburn Gresham, Englewood, New City, Cicero, and Little Village. They are either right next to, we had some raw space right next to a health center, or we even took 2 health centers and converted them into COVID testing sites, with the thought that, again, if there is a vaccine, we could quickly pivot and do mass vaccinations. Now, that's all well and good, but one of the things that we knew early on is that we had to have community engagement, and Dr. Gayle talked about that, and also Dr. Ezike. Before we even started, per each community, and again, we've got a long history of working with our various community partners, really engaging them, and here's our thoughts. What are your thoughts about how we could best engage, get the word out? Still a lot of fear, a lot of hesitancy about testing, but again, got a lot of what I call sage advice on the best approaches to testing. Historically, and unfortunately, especially in our communities, flu vaccines is still something that patients don't readily take. And so when you think about a COVID vaccine, I think Dr. Gayle was right. There's a lot of perceptions, whether it's, the politicization of it, to how fast it could get to the market, to even, what it could do to me, because people even heard some of the early studies. And I think right now it's going to be key to pull those groups together to start having a dialogue. but not just with the community, even with our own healthcare workers. This afternoon, we're going to be having some forums and continuous forums, not just on inside access and for all of our employees, not just on issues around race and health equity, but also their perceptions about the vaccine. You know, it's not uncommon for someone to come into our health center and their most trusted person is that front desk person who's been sitting there for 20 years, or that medical assistant, or even in some places, a security guard. And so we really have to make sure that we understand their beliefs, where they're at, and they can really be the ambassadors. You know, one nod which way can really impact a patient on whether they take the vaccine or not.
Donna, are you there?
Yes, I'm still here.
Okay.
And so one of the things that part of our lessons learned, not only around community involvement, but also as we even partner with some of our MCOs. Currently, they're able to go into our electronic health record and schedule patients who are high risk, some of those high risk members, also working with our care coordinators. It's also important as we think about technology to really use that as an extender. And, you know, when Dr. Ezike talked about, you know, the upcoming holidays, you know, we're looking at how do we do a campaign, not only for our workforce, but also with the community at large around family and friends and the necessary steps that they'll need to take in order to keep themselves and their loved ones and the community healthy.
Great. No, that sounds like you guys have a lot of experience in this regard. So having you at the table is going to be critically important. Samantha, are you there?
I am. Can you hear me all right?
Yes, ma'am. Good morning. Samantha, the I'm hip, as we affectionately call it, you represent Medicaid payers across the state who represent many of our most vulnerable citizens. And for those of you who don't know, the state's Medicaid program covers about 3 million of the 12.5 or so million Illinois residents. So 25% of people are currently using some part or all of the Medicaid benefit. What are the Medicaid health plans seeing on the ground with regards to vaccination rates currently, Sam? And how are you all thinking about, and how are we thinking about improving those trends?
Yeah, so thank you, Dr. Whitaker, for having me and for posing this very important question and dialogue, because what we're seeing, so to put the 3 million members in context, so it's about 25% of the population, but we are covering actually over a third of the children in the state. And then obviously we're also the largest payer for long-term care. So we've been particularly, our members have been impacted by COVID and then by vaccination rates. And what we've really seen in 2020 is not surprising, as everyone has said, a decrease in vaccination rates. In Illinois, we've seen the trends nationally, especially for younger children under 24 months, we're seeing very alarming rates. We are starting to see, which is sort of my small piece of hope, is that the first half of the year, so we track everything using our HEDIS measures, we saw significant drops. I mean, just truly jaw-dropping drops the first half of the year before July. We are starting to see trends return to normal or closer to normal, which is promising, but we're not necessarily seeing sort of a woodwork effect. We're just seeing a normal vaccination rate, which then means we're not picking up all those children who weren't vaccinated earlier in the first part of the year. We think that part of our increase in vaccination rates comes through a lot of the efforts that the providers, that the plans, and that we're collectively doing to encourage flu vaccinations. So people are going, families are taking their children to get flu vaccinations, and then they're hopefully also catching up on some of those other vaccinations that were missed earlier in the year. but we are still seeing significant decreases in just our standard vaccinations. And to really, I think, tie on to something that keeps myself and our clinical folks up at night is the conversation and the politicization of the COVID vaccine really ties into conversations that we were already having and already worried about vaccine hesitancy across the board. And so it sort of furthered that conversation and that concern. And so vaccine hesitancy was already a significant public health concern for all of us. And now we're almost seeing it sort of we're doubling down on battling vaccine hesitancy, having really frank conversations, empowering our clinicians and our provider networks on evidence-based conversations around vaccine hesitancy, because we are going to, for probably the next 12 months or longer, really have to have frank and scientifically led conversations around vaccines, not only for COVID, but for for a multitude of diseases.
What are in the light of COVID-19 and kind of everything that you've talked about, what is IMHIP anticipating with regards to vaccine policy over the next 12 months? Are there any sort of changes that we need or changes that you see coming? I know you heard about the report that Helene spoke of, and the governor's rolled out this, they're also thinking about the equitable distribution and getting to most needed communities fast. But are there any kind of policy changes or policy coming down the pipe that you anticipate or that you think we need to have in place?
So I think there are a few that we need to have, and there are some I anticipate. So I think depending, much like Helene spoke about, Dr. Gayle, I think that depending on whatever vaccine is approved, there may need to be policies in place and structures to provide effective and efficient vaccinations that may or may not utilize sort of our standard, you go to your pediatrician or your PCP for vaccinations. It may be more different events, and there'll be a lot of work from a public policy perspective that I fully anticipate that. What I think that we need to do from a policy perspective on sort of our traditional vaccines is change how information is shared from the Department of Public Health, specifically with Medicaid and Medicaid health plans. So today, pediatricians and physicians have access to eye care, the vaccine database, as does the plans, but really only one individual from the plan, typically our CMO, has access to eye cares. And we don't receive a flat file or any sort of large, sort of information about our entire membership. We receive member by member information. And why that's a concern from a vaccine perspective, especially when we're thinking about children vaccinations and the flu vaccine, is you don't necessarily get full gaps of care information that you can then share with your provider networks, because the health plan is only receiving information on vaccinations if they're billed for a vaccine. But as we talk about potentially, and we would strongly support access for vaccines where there's not a claim coming into a health plan, then the health plan is blind to whether or not that vaccine, whether or not that member got vaccinated, which means we can't then communicate with the member or our provider network about who's been vaccinated, who hasn't, where are the strategies, where are spots that have been under vaccinated, or where are sort of the areas of most need if we don't see that information. And so I think that's something we need to start doing now from a public policy perspective, get that live feed of data that is not individual by individual, but rather membership, so we can break that down, share those gaps of care with our member or with our provider networks, so we can collectively engage our members. I think it's important that we start doing that for our traditional vaccines and flu vaccines, so we can work out those processes, right? Like, it's technology, we're dealing with state files and HFS and then the plan. So starting now so that we can then do that work when a COVID vaccine comes through, I think will be critical. Or else the plans are flying blind and we can't serve as that additional resource or extender from the public health entities.
So Samantha, what you're saying is you want that data feed basically gives you with a population view. That way you can implement population health practices and you can more efficiently target your efforts. And so I think that's would be a piece of critical feedback we can give to the director. We told her we'd send her some critical feedback. So I'm going to need that just appropriately worded from you so we can get that as part of our recommendations. So guys, we have to wrap up here, which this is awesome. Donna, we got a question about the use of community health workers in supporting either kind of buy-in, if you will, from a trusted source role, and also just facilitating people getting to vaccines or knowing where they are and knowing where to go. Do you have any thoughts on the use of community health workers in the front line of COVID vaccine acceptance and distribution?
Absolutely. I think that that's a very viable strategy. The one thing, though, I would say we need to broaden who we think could have that impact. To me, let's bring in our faith leaders. Think people like, hairstylists, barbers, people who are well respected in the communities. We really need to get to them also to start the conversation. And so as community health workers, I think that that's one strategy, or tactic. But I think, again, we need to really broaden our net and really look at also those trusted community groups who have been long-term and have had a legacy of having great impact with and being trusted by those that they relate to in their own community.
And Donna, what you say, we've done these kind of campaigns before, right? Remember we talked a year and a half ago, we were talking about breast cancer awareness, and we had a crew of folks together who were involved in getting breast cancer screening rates up for Black women. Absolutely. And all women, remember? I mean, absolutely. We've done, yeah.
Well, I've got my pink on today, Cheryl, because it is breast cancer awareness. And I think one of the things I agree with Samantha and Dr. Ezike, we still need to continue, especially with this long legacy of healthcare disparities, in really working to get people and to stay engaged and get their preventive screenings. And at the same time, we just had an event with the AKAs of Evanston, not only getting the word out about breast cancer, but also talking about issues like COVID. So again, I think every touch point that we have with community partners, we need to have it as a teaching moment, but more a listening moment.
And we had a question in the chat that, when are we going to start pushing out the campaign to help people kind of depoliticize the vaccine and kind of right size the message? I don't know if we all have an answer for that. I mean, I think there has to be funding, guys, right? Like we've got to have the dollars to do that, right? Like no dollars have showed up yet for that. And so I hope that doesn't make us get too far behind, if you will. Samantha, any closing remarks from you before we?
Yeah, I just want to thank you, I think, for this conversation. I did see a question regarding, around vaccine hesitancy and those evidence-based conversations. We did a three-part at IMHIP. We did a three-part series on vaccines, engaging over 200 providers, advocates, leaders. Those are all recorded on our website, and I will send one of the specific one on vaccine hesitancy over to you, Dr. Whitaker, to share with the questioner. But we are. I just want to thank you for this conversation. I think Donna's absolutely right. Really listening, engaging the community, using unique resources. We're partnering with CPS on vaccination, education, and other public health components. So going beyond sort of what we think of traditional healthcare to have a broader dialogue.
Donna, any closing remarks?
Yes, I think as we move ahead, one of the things I'm most proud about in Chicago is how we've linked arms. And, from a state to local, where we're really bringing in the best ideas, we're learning from each other. And I think, again, that's really a hallmark of what we need to do as we go on this unprecedented journey together.
Well, look, I want to thank you both for coming on this morning and walking us through from your perspective, some of our opportunities and challenges. We got a great suggestion in the chat, guys, and I actually thought about this too, that students in nursing, medicine, public health, it would be great to train an army to help with, messaging, distribution. Imagine the creativity in this sort of generation of students in this space, but we'd have to have a vehicle to harness that and organize that. But think about it, the kids want to do something, right? So it's that could be a very interesting, not community health workers, but maybe even a mix of the two. I think it'd be a very powerful tool. So we do have a lot of, I think, great folks at our disposal. We just need some time to think about it and some creativity. We'll wrap these recommendations, guys, up in a letter to the director, Dr. Ezike. And so I really appreciate your time today. The next, we're going to go to a break. It's intentional from 9:30 to 9:40. And when we return, the next voice you'll hear is that of Raul Garza. Raul is the president and CEO of Aunt Martha's Health and Wellness. It's a federally qualified health center spanning, I think, multiple counties. They do a lot of work with also foster children. The title of the session is The Importance of Integrated Care in the COVID-19 Environment. So we look forward to seeing you guys back at 9:40. Take a break and please come back. Thank you so much, Donna. Thank you, Samantha. Bill Chamberlain from the Michael Reese Research and Education Foundation will introduce our next panel. Bill.
Thank you, Cheryl. Good morning and welcome to the State of Health of Chicago and to this session, which is on the importance of integrated care in the COVID-19 environment. I'm Bill Chamberlain, Chairman of the Board of Directors of the Michael Reese Research and Education Foundation and a former Chief of Medicine at Michael Reese. Our foundation endeavors to further the good works of Michael Reese Hospital through efforts supporting research, education, and clinical care in partnership with medical schools and hospitals in Chicago, as well as supporting scholarships for minority students. On behalf of the Michael Reese Research and Education Foundation, we are very pleased to sponsor this important session addressing integrated care in the COVID environment. This is clearly a challenging time for us all. It is therefore a great pleasure to introduce this outstanding panel. The leader of our session is Raul Garza, CEO and President of Aunt Martha's Health and Wellness. He leads this $75 million system of integrated healthcare, community wellness, and child welfare services with more than 35 locations, including 23 community health centers across 9 counties. Aunt Martha's serves over 105,000 patients and clients from some 600 communities. Mr. Garza is a passionate advocate for the underserved and an outspoken proponent of value-based care and cross-sector collaboration. Under his leadership, the agency has entered and thrived under shared risk, shared savings arrangements, and emerged as a leading provider of integrated, coordinated care. Our second panelist is Dorianne Miller, Associate Professor of Medicine and Director of the Center for Community Health and Vitality at the University of Chicago. She's a general internist providing care to underserved minority populations for more than 20 years. Dr. Miller has a special interest in behavioral health and works to improve population health outcomes for residents on the South Side of Chicago, through community engaged research and service models. She served as National Program Director of the New Health Partnerships, which was a demonstration project funded by the Robert Wood Johnson Foundation and the California Healthcare Foundation, addressing collaborative self-management support. Our final panelist is Maria Ramander, the Medical Director of the Substance Use and Prevention Program at Lurie Children's Hospital in Chicago. Dr. Ramander is an attending physician in the Tox-SNAC Family Division of Adolescent and Young Adult Medicine, an assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. She is board certified in pediatrics and adolescent medicine and serves as the medical director for the Substance Use and Prevention Program. I will now turn it over to Raul Garza to lead the panel. Please enjoy the session. Mr. Garza.
Bill, thank you for the warm welcome. And once again, thanks to the Michael Reese Research and Education Foundation for all the work that you do all the time, but especially for sponsoring this very important topic. So as I reflect on the last year, I hope that many of you will agree with me that we've seen heroes rise to the occasion. We've seen our healthcare system, like our country, being pushed to its limits. And we have felt, I strongly believe, with much more left to be revealed and much more left to be learned from, the profound impact on the COVID-19 pandemic on every aspect of our personal and professional lives. Now pushed to the brink, we find ourselves at a crossroads. The situation demands that our healthcare system, like our country, choose a new direction. It demands a system that is more representative and inclusive, whether it's from the State House to the boardroom, to the operating room, to the exam room. It really has to take a different direction at every level. It also demands a system that offers equitable access to care delivered by a team of providers who are able to respond to the patient's needs within the context of their community and coordinated by a team of professionals to help guide that patient on a path to better health. The situation demands, in short, an integrated system of care. It always has, but especially now. Our experience over the course of the past 9 months has revealed many things, including these two things. One, a new high-risk population of patients with underlying conditions who are particularly susceptible to contracting the coronavirus, and if so, are most likely to experience a difficult experience. And the increasing demand for mental health and substance abuse treatment services. So I hope that these two lenses will set up the conversation we're about to have and serve as a framework or examples in the first part of our discussion about the integrated care model. And in the broader context, the role of an integrated care model in the ongoing management of COVID-19 in our most vulnerable communities, affecting our most vulnerable populations. I'm pleased to be joined by the two individuals that Bill has introduced, each of whom is a recognized leader in the study, implementation, and impact of integrated care. I'm happy to welcome each of them to our conference today, and I am pleased to welcome our viewers and visitors. So with that, allow me to ask Dr. Dorian Miller to start with her presentation.
Great, thank you so much, Mr. Garza. I'm going to address the comments that around the issue of the importance of integrated care in the COVID-19 environment in the area of mental health. During the introduction, I was introduced as an associate professor of medicine. I'm actually a primary care doctor, a general internist, and spent most of my working life in under-resourced communities, both in the Chicago area as well as elsewhere, and also been involved in doing program design in the area of primary care mental health integration. Currently, I'm working with a group here called ECHO Chicago, which stands for Extension and Community Health Outcomes. And I've been heading up our integrated care and mental health for a number of federally qualified health centers and community health centers within the Chicago area in the areas of both serious mental illness as well as behavioral health integration through collaborative care. Now, oftentimes when we think about the issues of integration as scientists, as healthcare providers, we think about things from a population database, but there's something that I don't want us to forget. And so these next couple of slides, I think, will help to bring some of this home. Next slide, please. A collage of photos of the impact of COVID-19 on members of our community. As we think about both the briefings that we have received from the mayor around how we need to engage in terms of flattening the curve, whether it be from going into grocery stores and big box stores and seeing empty shelves of supplies. When we think about going for a walk as a young family with our child and having to mask up. And then also the incredible grief that so many communities have experienced around not being able to grieve for their loved ones in the way that they would normally do in terms of group gatherings at a funeral home or at a church. I think that all of these things make an incredibly difficult impact on the way in which we are accustomed to functioning as a society. In June, one of my clinic patients passed away, and I decided to go to the wake for that patient and literally stood in line with other family members and friends in order to go in to express my condolences and to view the body. Everyone was masked up, but because of the overwhelming grief that people were feeling, there were also lots of hugs that were going on at that time. And so the question of how we accommodate the impact of this in the long term, I think really extends itself into the human toll of what we're experiencing. Next slide, please. In addition to that, we also have been witnessing the incredible civil uprisings that have been a result of not only the murder of George Floyd, but also other murders that have taken place and have been brought forward through the media over the past several months. Sadly, there is a list of long names that are there, but as I think about the people who have been impacted by Black and Brown communities, this is another level of trauma that is impacting the mental health of the people that I care for as a primary care doctor, and as many of you care for, whether you be health administrators, psychologists, or for people who are looking at this at the population level, many of our scientists and health services researchers that we have on today's call. Next slide, please. And so what do we have here in terms of thinking about the impact of this? I put the photo in of a dripping faucet at the top in order to think about some of the baseline issues that people are coping with in their day-to-day lives. So as we think about the impact of mental health and the issues of COVID and integration, I oftentimes think about what types of things have impacted our communities from the perspective of the social determinants of health as serving as more of a baseline or a floor of why people come to us in the way that they do with their health concerns. And so water has sometimes seemed to be the most powerful force on earth. When we think about that dripping faucet, perhaps on a rock, we think about things slowly but surely wearing away the resolve and resilience of communities, whether it be poverty, whether it be transportation, food insecurity, et cetera, and all of those things that can impact one's physical health as well as mental health. Throw on top of that a hurricane, and so you can see the photo that's over in the lower left-hand side of your screen of a hurricane approaching the Florida Peninsula, and having that hurricane be COVID-19. However, as opposed to having this as just a short-term event and then the sequela from it, that is later followed by the tsunami that many communities have experienced in terms of the civil unrest and uprisings that we've seen as a result of the death of George Floyd and others. And because, as I said, we usually think of these as one-time, short, limited events, these are actually things that are ongoing. And so how do we think about accommodating the impact of these events along with the baseline events that so many people in our communities experience within the context of the delivery of primary care services? Next slide, please. So I'd like to make an argument for integrated care through primary care and mental health. This will be made from the perspective of demand and resources that exist, particularly for our mental health providers, whether they be psychiatrists or psychologists, but also from the perspective of cultural competence. The demand for subspecialty services really far outstrips the availability of these services and the resources, especially in our under-resourced communities. And so oftentimes patients have difficulty accessing subspecialists. There are also social and economic distance issues that reduce care availability. And in addition, by referring out into a community setting, oftentimes there's a loss of continuity of care for patients and providers. People have to leave their medical homes. They become very comfortable in the care that they have received in these medical homes with the group of providers that they've come to know over the years. And when they send them to see someone for something as sensitive and personal as mental health care, they sometimes don't go because they say, I know you, I know the kind of care and the quality of care that you provided for me in my primary care home, but I don't know these people that you're sending me to. And so how can I extend my trust that they will provide me with the same quality and level of care that's there? So again, those types of issues, in addition to just the day-to-day issues of how do I get there? Who's going to greet me when I get there? Transportation, other issues come into play. Next slide, please. However, I think that in terms of thinking about the reasons why that this is important, and particularly in the area of integrating care into primary care settings, a case example of serious mental illness in Illinois. About 5.4% of adults in Illinois have serious mental illness compared with 4% of the US general population. The shortfall of psychiatrists to meet the needs of people who have serious mental illness when they're referred by a primary care provider is anywhere from a 3 to a 10-month wait. In addition, there is a significant morbidity and mortality of patients who have serious mental illness due to chronic conditions such as heart disease, diabetes, obesity, chronic obstructive lung disease. And this patient population is less likely to receive preventive care. As I mentioned before, in terms of some of the issues around social determinants of health, there are high rates within this population of social vulnerability, high rates of homelessness, poverty, incarceration, and also social isolation. And then there are access barriers to quality care due to insurance. For those people who do have insurance, oftentimes it's Medicaid, and oftentimes the ability to access mental health services, whether it be for patients with serious mental illness or patients with depression and anxiety, are somewhat limited because of the patient's ability to have that insurance accepted by providers in the community. Next slide, please. The issues that I think that we're faced with are multiple. Cultural competence of the providers that are providing the care. The reason why I opened with the photographs that I did is that to acknowledge that in the time of COVID-19 and also this civil unrest that we're experiencing, that there is quite a bit of trauma that these communities have experienced. The issue of cost is also certainly a factor in terms of thinking about, is there a need to bring in other providers who can provide care for patients that have mental health challenges, and then thinking about ways in which you can do delivery system redesign and also redeploy resources within those settings in order to provide care. One of the things that we provide through the Echo Chicago program is decision support and also suggestions for delivery system redesign for community health centers and federally qualified health centers so that they can look at what they have and in what ways in which they can help to uptrain their providers in order to provide this care. Tracking outcomes is also something that's very important. And so for those of you who are leaders in your institutions, whether it be through insurance, HMOs, and others, you want to make sure that any of the changes that are implemented in your systems are actually tracking improvements in care and specifically treatment to target. And so being able to generate those mechanisms on how you are able to track them at a population level is very important. And then patient and community engagement, looking at whether or not there needs to be participation advice from the patient population that you're serving to see if they would be interested in receiving more of these services in a carve-in versus carve-out model. I'm sure that there are other issues that will come up, perhaps as questions in the discussion a little bit later, but I wanted to tee these issues up for us today as we think about ways in which we can address mental health integration into primary care settings in our communities. Thank you again for the opportunity to make these comments, and I look forward to our discussion a little bit later.
Dr. Miller, thank you for a very informative and important presentation, and we will circle back in a few minutes. At this point, I want to introduce Dr. Araya Ramandar, who once again is with Lurie Children's Hospital. Dr. Ramandar.
Hi, everyone. Thank you so much for having me. I am Mariah Ramandar, tough name, and I am going to be talking about adolescent substance use and co-occurring mental illness. and the importance of integrated care to battle both of these issues. I really appreciate Dr. Miller's context of the racial inequities that are going on and how this health crisis that we're experiencing with COVID is exacerbating those. Next slide, please. So by the end of this session, I hope that we'll be able to discuss recent trends in adolescent substance use, articulate the importance of integrated care in adolescent substance use treatment, and also just give you guys some information on how to refer to our program if you have patients or family members of patients or people you're interacting with in the community who may benefit from our program. Next slide. So just to set the scene, this slide is showing the most common substances used among high school students. And this is freshmen through seniors. You can see that dark blue line is the percentage of students who reported ever using these substances, and the light blue line above it is the percentage of students who reported current use, so meaning past 30-day use. And this is in our state, in Illinois. So the most common substances are alcohol, with just over half of students reporting ever trying using alcohol, and around just under a third reporting currently using in the past 30 days. E-cigarettes is next with just around half reporting use and around 20% reporting currently using. Marijuana comes after that with just over a third, and again, around 20% reporting current use. And then cigarettes, and this has continued to go down over time. Next slide, please. And really the health crisis that we're experiencing right now has increased overdose deaths related to opioids in particular, and some other substances. And in Chicago in particular, this is disproportionately impacting Black people, especially Black males, compared to other populations. And next. And we are seeing a mental health crisis increasing among our teens who really everybody's life has been turned upside down, and this really important developmental stage is really being turned on its head with everything changing in their lives. Next slide. So there's a giant treatment gap in our community, and I mean in our country and probably the world, and we see this in adults, but even more so in teenagers and young adults. So young adults are the age group with the highest need for substance use treatment. Around 16% of 18 to 25-year-olds meet criteria for a DSM, the DSM criteria for a substance use disorder, and that's around 5% for 12 to 17-year-olds. And then few who need treatment actually receive treatment in a specialty facility. So that's around 6% of 12 to 17-year-olds and 8% of 18 to 25-year-olds who have a substance use disorder receive treatment in a specialty facility. And it's rare for adolescents and young adults to perceive a need for treatment. And I think everybody is aware of that. So only 1% of teens and 3% of young adults who met criteria for a substance use disorder, but were not in treatment, felt that they needed treatment. So this brings up the importance of interventions that can increase motivation to engage in treatment, and also the importance of considering treatment outside of specialty facilities in a primary care setting and other outpatient settings to increase access to care and break down some barriers. All right, next slide. And so here's a traditional model of care for substance use and mental health conditions where you have these different levels. So early intervention, so really kind of meeting people before, well, I'd say prevention is even in front of that. And then you have early intervention. So trying to tackle this issue when somebody's just started trying some things, dabbling before they've really met criteria for a substance use disorder. Then there's outpatient treatment. And that really traditionally is seen for people who aren't engaged, in like moderate to severe substance use. But I'd like to argue that that's kind of an old-timey way to think of treatment. And then you have the higher levels of care, so intensive outpatient, so a couple hours a week, a couple times a week, partial hospitalization, a couple hours a day, most days a week, but sleeping at home and going home on weekends. And then you have residential and inpatient. And then there's aftercare, which may be the most important level of care. But like Dr. Miller brought up, behavioral and mental health wait times are out of control. There are very few adolescent specific treatment programs for substance use and even for mental health. But thinking of primary care settings where they can provide these things, the levels of care that I bolded, so prevention that I didn't have on there, but early intervention, outpatient, and aftercare services are really just like tailored for somebody who knows this patient, who can see them over time. And this is really important since substance use disorders are often considered chronic diseases where recurrences are common and really can benefit from long-term follow-up. And these may not always be chronic issues for teenagers. Luckily, most teenagers are resilient, and people who use substances often don't end up having a problem. But this can be monitored over time to intervene when it looks like somebody is developing a problem and help people manage that long-term. Next slide, please. So treatment for mental health and substance use disorders often occur in different silos and is really, of course, undertreated. So in our state, I just wanted to point out that minors can consent to substance use treatment under Illinois law. However, family involvement can be beneficial and improve outcomes and improve, follow-up and engagement, and really kind of setting up a healthy environment for recovery in their home, as well as, helping family members who may need mental health or substance use treatment engage in care as well. So motivational enhancement therapy and cognitive behavioral therapy have been shown to be effective, as well as I just wanted to mention that there's some ways to increase this. We see that a lot of teens are not interested in engaging in care, but we have some techniques that can help people increase their motivation. So whether that's, motivational interviewing to increase the internal motivations to engage in care, but also providing external motivations in terms of prizes or gift cards for engaging in care, and seeing some reimbursement would be great for those to not have to get the money for those from other sources. So really co-occurring mental health issues is really the rule as opposed to the exception for teenagers who have substance use disorders. So really it's ideal to not have to say, oh, what's primary, where should you go, but really being able to kind of handle those both in the same setting and work together as a team. And so in having a substance use disorder during the teen years increases the risk, if you don't have one already, of having a mental health issue as an adult, and increases suicidality rates as well. Next slide. So just really quickly, wanted to let you guys know about our substance use and prevention program at Lurie Children's. So we are off-site from the main hospital. We're in the New City area of Lincoln Park, right by the North and Clybourne Red Line stop, and off 94 at the North Avenue exit. So we are not a freestanding substance use treatment program. We are really embedded within adolescent medicine. So that can kind of decrease the barrier for a teenager to be like, I don't need treatment. I'm not going to some treatment facility. This is in an outpatient setting, going through the same doors as people who are getting their checkups, getting their, vaccines, getting STD checked, birth control, everything like that. Gender care, same building, same waiting room. And that's our team. We have our administrative professionals, psychologists, who have background in trauma, our LCSW, who does the bulk of the therapy as well, a social worker who reaches out to patients to do some case management between visits, as well as a nurse practitioner, who's the other medical provider who does work with me. All right, next slide. So if anybody wants to refer to our program, calling 1-800-KIDS-DOC, and that's our website. And that's the same way you refer to any program at Lurie. So hopefully that's easy to remember. For people who need help outside of, who may not be interested in our program or kind of outside of people we would see, our age group, you can call the Illinois Helpline for Opioids and Other Substances, and they'll match people with treatment providers based on insurance and location in the state. Considering prescribing buprenorphine, it's really easy, really rewarding, and they're free training and other education at pcssnow.org. Encouraging people to access naloxone who are around people who could experience an opioid overdose. And then here are some parent resources really geared towards teens, specific to COVID, but also just substance use in general at this American Academy of Pediatric websites there. And I'm looking forward to answering questions and discussing more.
Thank you. Really appreciate the reference resource material as well. So let me ask the two of you a question that I think is probably on a lot of people's minds, and that's, what have we learned about the value of virtual integration over the course of the pandemic? Dr. Miller, would you like to open?
The issue of virtual integration over the course of the pandemic. And when you say virtual, you're referring to virtual visits?
Telehealth, right? The expansion of telehealth, right?
Exactly. For me, it has been a mixed blessing. And I'll start with some of the positives, and then I'll end with some of the challenges. To be able to have a lens into where my patients live and to do a virtual house call, if you will, is something that I've found is a real benefit. Being able to do virtual visits as well as continuing to literally see my patients, I think has been a real benefit. However, one of the things that it's uncovered for many of my patients is the issue of having a digital divide around access to the technologies that's necessary in order to be able to see them. I'm a primary care internal medicine doctor. I care for a number of people who are older, and the way that some of them have been able to work around this is to have the engagement of younger family members to get them onto a call, whether it be a built-in video visit in my electronic health record platform or onto Zoom or Doximity in order to be able to see them. And sometimes it works and sometimes it doesn't, but I think that it's been much more revealing that we have so many people who are living in communities within the city of Chicago for whom that there's a real digital divide. If we're going to continue to expand virtual visits, and telehealth, I think being able to address the widespread use of digital platforms for communities that are under-resourced is something that's critical in order to make that work in the future.
Great, thank you. And Mariah, what's your experience been like?
I think really similar to Dr. Miller's, where I think this has really been a great advancement in increasing access and kind of the ways in which people can access care. This has been wonderful for my patients who have gone off to college or some other, training away from their home to be able to check in and do visits virtually and not just have to say, okay, I'll see you if you come home for the holidays. But it has really continued to broaden the chasm between, the socioeconomic disparities and where people do not have, access to internet at home. And, we don't get reimbursed for telephone visits. We still check in that way because it's important and we don't want our patients to have no care. But the reimbursement structure really needs to change to meet the needs of patients, in addition to really helping get technology more broadly into communities that need it the most.
Well, I appreciate what you just said about the reimbursement structure. So I'm going to stay on that point and ask, maybe from a managed care perspective or an insurance provider perspective, do we need to change how we view or even stratify patients based on the risk of contracting COVID-19? Mariah, let's go with you since you brought up that point.
I deal with, I mean, certainly I see a younger age group. So I see I don't really see the young kids in my house. I have the young kids who are low risk for contracting and spreading, but I see the population of people that are currently responsible for acquiring COVID right now and spreading it. And so I'm not seeing the communities who are dying from it. So I will defer to Dr. Miller to talk more about that. But what I think we need to really, we can't rely on an executive order long term. But this health emergency has I think has done a wonderful overhauling of how we can provide care. But we need to see long-term changes in being able to continue to connect via telemedicine, considering telephone visits, as well as valuing the other, providers on our team. So our social workers who, mostly go unreimbursed in their work, we have to, support in other means, that is so important for case management and check-ins, and also in order to provide truly integrated care. So where it's not like I'm in my office, the patient sees me, and then we switch places, and they go down and see the behavioral health person, or they call into their therapy visit. We could work together and be in the same room together and be, paid for work we're doing, where the patient doesn't have to repeat themselves, and we can really work as a team and talk as a team with the family and the patient and the other providers. That would be really important to really promoting integrated care.
Yes, I agree. Dorian, what do you think about that?
Thank you so much, Raul. I think that the kind of risk stratification that you speak about and figuring out ways in which there can be better reimbursement for care coordination under these types of models is absolutely critical. I was on a call yesterday with a number of my community partners who were discussing the issue of how in many settings, youth are concerned about going out and bringing COVID-19 to their older relatives who have chronic health conditions because they're having difficulty getting something as simple as being able to afford to have a mask or face covering. And so the question of figuring out ways in which we can provide adequate care coordination at a distance so that we can serve the needs of the populations who are at higher risk for COVID-19, absolutely critical. One of the things that we have seen both in our African American as well as Latinx communities, because of multi-generational living and because of people living in more crowded conditions, is that there's been much more spread of the virus for people who live in those settings. And again, those are the people who, unfortunately, when they become sick, because of their underlying health conditions, they end up having much more complicated courses, including hospitalizations and sometimes deaths. So I absolutely agree. We need to do a little bit more risk stratification based on the population and their risk factors.
Great. Thank you. Well, I think we've got a few more minutes because we had an extended break there. So I just have one more question because I don't see anything in the chat room. However, as far as the question goes, I do see a lot of positive contents about your presentations, both being relevant and important at this time. So let me ask you this last question. As a healthcare system that includes the Illinois Department of Healthcare and Family Services, the managed care providers, providers like the University of Chicago, Lurie Children's, Access, Aunt Martha's, et cetera, how do we use the experience we're in right now as an opportunity to really intentionally ensure that there's more of an integrated approach to care? I often say within our organization, many of us in the community are touching the same patients. However, we're not necessarily talking to each other about what's happening in that patient's treatment, regardless of what role we play in the cycle of care. So how can we take this experience and treat it as an opportunity to ensure that we're all more integrated as a network?
Population health improvement is team play. And whether we're talking about a academic health center, a community hospital, home health care agencies, substance use providers, mental health providers, having a background platform where there can be an exchange of information around the patients that we are serving as a community, I think is absolutely critical. We're facing the closure of one of our hospitals here on the south side within the upcoming year, Mercy Hospital and Medical Center, which is actually the oldest hospital in the city of Chicago. Many of you may not realize that, but was started back in the 1840s. And it's going to have a tremendous impact on the ability to provide care for people who live in the Mid-South side. That particular institution not only provided care, but also in the area of cultural competence. And so thinking about people whose first language is not English, whether it be people from the Chinatown Armour Square community, from the near west side for whom people may speak Spanish. And so the question of thinking about how we can think about this as a network and the kinds of services that are needing and having people to talk to one another about those services, I think is absolutely critical. I think that the generation of an information technology platform may be a step in the right direction in terms of providing that type of infrastructure, but also opportunities for person-to-person, institution-to-institution care and coordination of services will help to fill this gap.
Thank you, Maria.
I don't have too much to add onto what Dr. Miller said, but yeah, I think that technology is really going to be where it's at because, you know, the hospitals have the infrastructure to deal with technology, and I think community programs have a variety of ways. But you know, I think I'm hoping that we're going the way of no longer having conference calls, but that we're connecting, you know, even face to face over Zoom. It makes a huge difference, I think, in connecting, you know, people far away. So whether that's community groups with medical and behavioral health providers. And so, you know, I'm hoping that we keep, you know, collecting releases of information and connecting with our social workers and connecting with community groups so that we can all take care of, you know, people together, because so little of the work that keeps people healthy happens within like the walls of my clinic. I mean, it really takes the, you know, the world outside to promote health and wellness. So.
Thank you. Thank you to both of you, Dr. Dorian Miller and Dr. Mariah Raymond. Really appreciate you pulling yourself away from critical work, seeing patients and working with our communities. And we're very fortunate to have had you participate today. Two world-class physicians serving and leading world-class healthcare institutions right here in Chicago. Thanks for making this a rich dialogue and for really imparting a lot of great knowledge about what is really happening and what works. So thank you. At this point, I'll turn it back over to my esteemed colleague, Dr. Cheryl Whitaker, to take us to the next phase. Thank you, everyone.
Wow, thanks so much. Thank you, Dr. Miller, Dr. Ramandar. Phenomenal panel talking about our children and our teens and mental health. So this critical conversation, very important to the dialogue. We're going to take a break. When we come back, we're going to jump right into a conversation around maternal mortality and morbidity in the context of COVID-19, but kind of even before that. All right, so take a quick break. You'll hear some music. We'll start up right about 10:32. We look forward to welcoming Dr. Robin Jones, who's an associate professor of OBGYN at Rush University Medical Center, and Dr. Lisa Green, founder and CEO of Family Christian Health Center in the South Suburbs, Harvey, Illinois. Thank you. So we are back. For our next panel. Oh, goodness, I'm getting some reverb. Why is it? Dr. Green? Are you with us?
Yes, good morning.
Good morning, Dr. Green. Dr. Jones, are you with us?
Yes, Dr. Jones is with you. I need you to start my video, please.
1 second, Dr. Jones. Give me a second. So I want to introduce the panel. No problem. I want to introduce the panel before we get started. We'll spend the next 40 minutes or so talking about maternal morbidity and mortality. We're going to use COVID-19 as a part of our context, but we know that these disparities were in play much well before that, and that COVID-19 shone a light on some of the critical kind of missing pieces in our ecosystem. I've got two great panelists with me today. Dr. Lampley could not make it. He did have clinic. He's the director of high-risk OB at Sinai Medical Center, but we do have a few sort of pearls from him that I'll share as your moderator for today. Dr. Lisa Green is a family medicine specialist at the Family Christian Health Center in Harvey, Illinois. She has over 29 years of experience in the medical field. She graduated from the Des Moines University College of Osteopathic Medicine in 1991 and is affiliated with Ingalls Memorial Hospital. Dr. Green has a degree focused and a master's degree focused in the Department of Health Policy and Administration from the University of Illinois College of Medicine. And just more importantly, she's really on the front lines of caring for people in our community every single day, and is a passionate advocate and practitioner and implementer, go-getter to make a difference in the community. So welcome, Dr. Green. Dr. Jones is an associate professor of OBGYN at Rush University Medical Center. She serves as the chair of the Illinois Department of Public Health Maternal Mortality Review Committee and is the clinical lead on the Birth Equality Initiative for the Illinois Perinatal Quality Collaborative. She's a native of Chicago and continues to work in our community as co-chair of the Westside United Care Coordination Work Group. She has served on the Illinois section of the American College of OBGYN on the executive leadership team, and as a senior medical director for several managed care organizations. So we're pleased to have them both here with us today, representing OBGYN family medicine. I'm representing internal medicine. But just know that while we're coming from the medical perspective, that we've broad interest and experience working holistically with our community and working on interdisciplinary teams. So I'm experiencing feedback on my end. Dr. Green, are you hearing that feedback when I speak?
Cheryl, it's Cheryl. Might you be logged in twice?
No, I'm not.
Now we don't hear it.
Yeah.
Hi, everybody. Dr. Jones, actually your audio for some reason is causing that. When you're not speaking, if you can keep yourself muted, that will help us a lot. Thank you so much.
All right, so we can get started with Dr. Jones. Dr. Jones, we want to start with your kind of opening remarks and comments.
Good morning, Dr. Whitaker, and thank you so much for inviting me to be on this important panel. I'd like to start with Jasmine. Jasmine is, or should I say was, a resident of Illinois. And Jasmine didn't have a voice, and today she will have a voice. Allow me today, in this moment, to be Jasmine and her voice. Thank you, Dr. Jones, for this invitation. My name is Jasmine. I was an African-American woman in my 20s. Throughout the end of my pregnancy, I had frequent pain in my side and pain and numbness in my leg. And during my pregnancy, I visited the hospital department 8 times for various reasons, including pain. I delivered a beautiful, healthy baby boy, but experienced severe leg pain during that hospital stay. I was discharged from the hospital the day following my delivery, and I was instructed to return for an MRI if the pain persisted. I went to the emergency room twice the week following my delivery. The first time I presented to the hospital, I was admitted for pain management and discharged the next day with ice packs and pain medication. 3 days later, I represented. And this time, I had an examination which was limited by my pain. And all in my leg were not thoroughly examined for blood clots. I was discharged and told to follow up with my primary care doctor. Please note that I was screened for drugs multiple times, and repeatedly my screen was negative. By the way, no, I do not have a history of prior drug use. 1 week after my last visit to the emergency department, I collapsed in my home. I was taken to the hospital in cardiac arrest. I, Jasmine, died 18 days after the delivery of my beautiful baby from a blood clot that had traveled from my legs to my lungs, a pulmonary embolus. I, Jasmine, was denied the opportunity to be the mother that I had envisioned being to my beautiful baby. I, Jasmine, was denied the opportunity to contribute to my family and community in a meaningful way. I, Jasmine, was not allowed to be the matriarch that I envisioned for the next generation. Thank you, Dr. Jones and Dr. Whitaker, for allowing me to have a voice. I hope my voice is heard not only in this forum, but across this nation. My name is Jasmine. Dr. Whitaker, I wish I could say that Jasmine is the only case, but she's not. If we look at the maternal mortality rate in the United States, while nations that rate is declining, in the United States of America, that rate continues to increase. And not only that, there's vast disparities in racial and ethnic backgrounds. This is in the United States of America.
So it looks like we may have lost Dr. Jones. Dr. Jones, are you back with us?
I'm here. Can you hear me?
You dropped off. You said your last thing you said was the United States of America. So why don't you start back there?
I think it's important that we realize that maternal morbidity and mortality is viewed internationally as an indicator of the health status of a nation, of a community, and of a state. And while maternal mortality is declining in other developed nations, maternal mortality in the United States of America, this beautiful, powerful country, is increasing. And not only is it increasing, but there are vast disparities when you look at racial and ethnic profiles. This is a public health emergency. It is a public health issue, and Jasmine, unfortunately, and her family have not been the only ones affected. Thank you, Dr. Whitaker.
Thank you, Dr. Jones, for kind of opening us up here and giving a voice to Jasmine, who died of a blood clot that traveled from her leg to her lungs. Dr. Jones, what you describe is, you didn't describe a trouble with access to actual care. And would it be safe to say that Jasmine received the majority of her prescribed prenatal care?
For Jasmine, access to care was not the challenge. For Jasmine, not being heard, not being listened to, unfortunately, not making an appropriate diagnosis, that resulted in her demise, unfortunately.
So we talk a lot about implicit bias in the system. You said she was reviewed for drugs several times, but never sent for that screening ultrasound, DVT kind of review. What is your thinking there about the implicit bias, and what is our opportunity as a profession to try to make a change here? So Dr. Jones, we don't hear you.
Implicit bias exists. It's not new. If there's any good news about this, Dr. Whitaker, is we're at least having the conversation. We have at least admitted that there's a problem with implicit prejudices or implicit bias. The question is it only implicit bias? Yes or no? What does one do with implicit bias? And does it only exist within certain communities? But let me state this, implicit bias does exist. Unfortunately, it's more common within certain communities. And until we decide that this is affecting health outcomes across our nation, maternal health, when you look at Latinx and African American women, our outcomes will continue to be unfavorable. In the nation, African American women are 2 to 3 times more likely to die from a pregnancy-related condition. Unfortunately, when you look at our state, African American women are 6.5 times more likely to die from a pregnancy-related condition. That's not just due to access or comorbidities. That, Dr. Whitaker, is due to implicit bias structural racism, social determinants of health, health literacy, employment or unemployment, quality of education, food deserts, housing availability. So this is bigger than healthcare. And we all own this one. And therefore, we collectively have to come together. And when I use the word we, let me define we. We means the healthcare providers, the hospital, insurers, policymakers, government officials, the community, and patients and their family.
Thank you, Dr. Jones. I want you to put a pin in that and then put yourself on mute. We're gonna go to Dr. Green for her opening remarks and comments. Dr. Green, you know, we convened together back in February, and you may touch on that, but we're going to do that after your comments if you don't. But can you kind of, you're the co-founder, CEO of Family Christian Health Center. It's in the South Suburbs. And, you know, you have some kind of firsthand experience with the ability to appropriately refer women who may need that next level of screening, ultrasound, or been identified with an issue. So I'm going to ask you to kind of start with your opening remarks, please. And
Sure.
then we can have a discussion.
You know, thank you so much for the opportunity. You know, when listen to Dr. Jones tell the story about Jasmine getting a voice, you know, and she talked about we. I say the same thing when we talk about the Constitution, we the people. Well, we on this call just heard a story, and so Jasmine does have a voice, right? Because it's up to us. We are the people that can fix this. So that way, when we take the information that we have today, it doesn't just stay here. And so one of the things I really want to stress is the ability for us to really own the situations that we see that are occurring, and then how do we collectively do that? So part of the challenge I realized when I really became aware of how bad the statistics were, I was like, oh my God, you got to be kidding me. I'm a physician, I work here every day. I'm a county trained physician, south side of Chicago. Our clinic is in the far southern suburb, I was in the southern suburbs and the far south side, but we service 59 zip codes. And that being said, I was appalled at the numbers. And we got together back in February and put a forum together, and it was called Breaking Silos and Taking Action. And it was an amazing opportunity that we had healthcare professionals and social service agencies throughout the city who were doing work, but we weren't talking to one another. And so this gave us an opportunity to talk, to share. How do we change things? How do we make it better? Because the people that we're talking about, Jasmine on this call could be somebody's sister, neighbor, friend, aunt, somebody. And so therefore, this opportunity allowed us to really begin to network. And how do we move the needle forward, right? We have the data, we see what's here. So how do we put changes in place that allow us to do that? Well, our next step was to take the information that we had learned and then move forward. And then COVID hit. And all COVID did was uncover the problem that already existed. For the south side of Chicago and far in the southern suburbs, if you look at the catchment area, there are about 300,000 women of reproductive age in the surrounding communities. Well, of the hospitals that women had access to care to, 3 of them had already closed their borders within a short period of time. And then post-COVID, due to economic safety reasons and things like that, those women found themselves having access to other institutions. Not only the women, but the providers themselves were trying to figure out, you know, where do I send my patients? How do I navigate this? And we were having trouble before that, but now that COVID has existed, it was even more complicated. When we think about a woman that's on the south side of Chicago and she doesn't have access to necessarily a medical district where you have a catchment area of proximity hospitals that you can go to get testing to. You can be on the south side, and if I need to get you to a maternal fetal medicine physician, can be a 2-hour ride to the hospital to get that test, right? And that's just one way. So we're not even talking about coming back. On top of that, imagine me trying to navigate that in the middle of COVID, and I have 1 or 2 other kids with me on public transportation. And so when we looked at some of the barriers and things that we were discussing, we put a Facebook Live together. And when we put the Facebook Live together, which was in May, it was amazing opportunity for 5 to 6 OB-GYNs who are out doing this every day to come together to really talk about the structural and challenges that they had faced prior to COVID, but now with COVID, the other complications. The good news out of that conversation, though, as I remember getting a phone call back from Dr. Gayle and said, you know, Dr. Green, we heard part of the conversation about blood pressure cuffs, and that one of the doctors was really having a challenge just getting a blood pressure reading, and how she was able to have a conversation, get access to someone with a blood pressure cuff, and that woman's life got saved by coming in early, right, for preeclampsia. He ended up talking to Teresa Eggleston and end up changing policy so that all women in the state of Illinois on Medicaid get a blood pressure cuff. And I was floored. We were back almost in tears, because for something as simple as that, if you're out trying to navigate and take care of a patient, that's huge information. That's huge data that you can have access to make your changes and be able to provide care. And you would say that a blood pressure cuff is, $40. But if you don't have that $40, if you don't have access to even getting to the store to get that $40 for you is like having $4,000.
So Dr. Green, I just want to stop you right there, because there's a couple of things you're kind of getting at here. One is during COVID, we started doing telehealth visits, and again, the jury's out on where telehealth is the most effective. But in this case, there were women who were assigned telehealth visits who may have been at risk for kind of developing preeclampsia. And we started seeing them over the phone, and it wasn't clear that that vital sign was being captured, right? So we leaned in, and we were able to connect with the state director of public health and a state director of Medicaid. And so you're right, we did make that an aware policy that went into place. But can you talk a little bit about the sort of failure of telehealth when we're trying to really monitor women at high risk for developing like a preeclamptic type picture, and why in COVID-19, for a number of reasons, that probably did not work?
Telehealth gives you a snapshot. When you're pregnant and there's complication, you don't need a snapshot, you need the whole story. And that whole story needs to be face-to-face. It needs to be an on contact where you can actually talk to the patient, but you can actually listen to them, that you can check their fetal height, that you can do an urine dip. So telehealth works great for low-risk women who you can get some initial prenatal care visits. But for a lot of our patients, what happens is there are other complications, and as Dr. Jones mentioned, those other social determinants of health impact things. These women were trying to do Zoom calls with their kids for school. They were trying to access all that was happening on the Black Lives Matters, and all these other complications and stress and social other barriers that impact that. We know that those outcomes or those impacts also have a huge impact on pregnancy. So because of that, these women still needed to be seen, but the barriers that we had prior to COVID only got exacerbated during COVID, because now there are choices and limitations to them getting access to the care. And same thing with the doctors trying to find places where they can go, who will take their insurance, how are they going to get there, how do I get the care coordination? These are all factors that we can lay down and they look good on paper. But you try picking up the phone and calling and navigating that and connecting that woman to do that. That's a different story. That is a very different story. And so I think lesson learned from this is that, yes, in instances, we absolutely need telehealth to be able to do it, to give that snapshot, that image that allows us to connect. Maybe you get a chance to connect with the dad in that scenario. Maybe you get a chance to see some of the other issues and conversations of family dynamics, but for women that have complications with diabetes, hypertension, thyroid, other issues, those women need access to care that is within proximity, that is within their reach, that helps partner with their primary care providers as well as with the specialists to make sure that they have an ecosystem for success. So then we're not listening to them 2 years from now or another year from now, and it's not a Jasmine, but it's somebody else's voice that we're listening to.
So Dr. Green, I'll never forget the day that we heard that. So you touched on another issue, which is really failing networks for referral for labor and delivery. I'll never forget the day we heard that St. Bernard was abruptly closing their labor and delivery. And then in short order, Advocate Trinity closed their labor and delivery. And a bunch of us African-American doctors from internal medicine, OBGYN, family medicine, we hopped on the phone because we were horrified. And you're closer to it because you're at Family Christian, you're referring women into some of these facilities. And I want to say, Dr. Green, that, you know, in retrospect, the New York Times somehow found Dr. Bradshaw, Joy Bradshaw, who's over at St. Bernard, who was an OBGYN there. It got more pub from the New York Times and other places than it actually did here about what the impact would be on the women who were seeking pregnancy care. So can you, just for the audience, kind of recount how you remember feeling and what you felt and what you sort of experienced when you heard St. Bernard, then Advocate Trinity were both closing L&D during the midst of COVID-19?
I personally was horrified because we know how far and how many barriers that our patients have and the outcomes. And so several of us got on the phone together to try to figure out, and I noticed some of the doctors were talking on Facebook. How can you go on Facebook to look for access to get your patients? That made no sense to me whatsoever. I said, there has got to be another mechanism of way of communication. I realized that we were all running at 50 speeds, but at the same time, it was our duty and obligation for these practitioners, providers, as well as the patients. And so that's when we really began to, how do we communicate this with one another? What was that network like? You have physicians who, yes, their information had been communicated, but physicians who worked at some of the institutions who still didn't know what some of that communication was. And so I think, can we do better and we can learn from this? Absolutely, we can. And I think that when we do that, what happens is you open up the door when you really include some of the providers, because I think sometimes what happens is we have the network of administrators as we're working through, we will have the medical director, but sometimes the voice of the actual people that are boots on the ground doesn't necessarily make it up to the 5th floor, right? And so I think we have to do a better job of ensuring that the voices of the people that are out doing the work still have the ability to be heard in some of the decision making. And that's how you prevent the New York Times present an article out that locally here we didn't know about.
Well, I want to applaud, though, Dr. Green, like the network of physicians that came to the table, really. You know, Ingalls, chair of OBGYN, got on the phone with, you know, all of us, plus University of Chicago docs got on. And we basically, with bubble gum and tape and string, tried to just figure out what we could do, because the system itself was failing, right? The networks were experiencing massive failure of network. And I think what, you know, we can all agree on is that we'll never really know. We'll know in retrospect once we look at the data and we have the information on who delivered where and what their outcomes were. We'll never really know the impact on the physical health of that mom. And I doubt if we'll ever know the impact of the mental health disruptions that were caused. So, you know, this is a great collective group on the phone. And I'm hoping that you and Dr. Jones can sort of make a few recommendations. We've told the Director of Public Health, you know, and we can do the same for the Medicaid Director, that we want to put together a series of recommendations that we like to make. But before we do that, we talk about hospital closures, and again, that's about networks, failing networks that are beyond our control in many cases. what did you all think about sort of the Mercy closure and the impact that it might have? Lisa, it's out of your service area, but do you have any thoughts there? And I'll let Dr. Jones go first. Dr. Jones, are you there? I know you. What are your thoughts there about the sort of network adequacy and proximity to services?
Well, when you use the word network adequacy, I think the word you really want to use is network inadequacy. Because as we close more and more hospitals throughout this city, it has to have both direct and indirect impact on the most vulnerable individuals in the city. So it's alarming to hear that in the midst of a pandemic, labor and delivery units are closing and hospitals are closing, but we have to come together and make maternal health and maternal health outcomes a priority. It has to be a priority. And until we do that, unfortunately, I think we'll continue to see inadequate health care within not only this state, but across this nation for vulnerable groups of individuals.
Thank you. Dr. Green?
I think that, I mean, I have to echo what Dr. Jones said. And we realize that hospitals have financial constraints, there are things with safety, because one of the hospitals did, Trinity opened back up because part of the conversation that they had was they didn't think they could do it in a safe environment. And that's understood at the time. But what's not understood is that the level of communication down that really reached the provider so they could provide care and be involved in that decision. It can't be the afterthought and the response. I think we're better than that. I think there has to be the ability to have communication with the people that are boots on the ground, that are doing the work, not necessarily reading a report about what they do, but actually having them at the table so that when the decisions and the communications are made, it is transparent, it is allowed to be able to take that information to ensure that there are safety measures, that there's other educational tools that need to be mended together before a final, wake up. Because what happened here was, oh, it's not happening tomorrow. And so we've had to then find ways to then navigate through that system. And so I think that as we look at this, I totally agree. We have to make it a priority. And as we make it a priority, then we put the resources and we put the pen to paper with policies to ensure that we have an ecosystem that works for the South Side. I think, it goes back to, and I keep saying, we don't have what takes a 15, 20-minute transportation in the rest of the city can take 2 hours on the South Side of Chicago to get someplace. And that's a real issue for people. And so when you talk about access, it also has to be not just with insurance or the providers, but it has to be within a proximity that's reasonable enough that will allow patients to be able to get in at a sooner time and allow the providers that are working to know that when their patients are coming through the door, that they have not had all these extra barriers. We can't always fix everything, right? You're not going to fix poverty overnight. You're not going to fix, but the things that we can fix, we have to make that a priority to do.
So just to share with our group here convened is on Monday, the Illinois Senate convened the Public Health and the Human Services Committee. They had probably 15 speakers, and this came up several times. The maternal health desert, Southside is a case study, if you will. There's certainly other areas in our state that are impacted. But the health of women overall, it does need to become a priority if we're procreating and providing the next generation, of life. That we are conscious and we're making conscious decisions. So I think honestly, perhaps a recommendation that a real work group, right? So we have to have solutions that are sustainable or viable. Maybe Mercy doesn't have as many beds. Maybe it's a smaller hospital, but it's still offering necessary services, right? Like, what are the solutions that are financially viable and make sense? And then number two, we have to ask the questions of where are we currently spending money, because we are spending quite a bit of dollars in healthcare in Illinois. Like for the Medicaid budget, it's well over $20 billion. So where are these dollars going? That we also have to ask, because is there a structural financing issue that is causing this level of closure? Hospitals are shutting down services. In some cases, they may be open, but they don't offer, certain services, right? So we also have to be thoughtful about not just the doors open, but that the services that community needs is available. So I think, yes, go ahead, Dr. Green.
I think, and the other thing that we have to look at with all this modern technology, we have to look at a platform that really allows people to be able to communicate, the providers. It is very difficult and challenging for patients that are now just showing up at the hospital. That happened before COVID, but now when patients just show up and it's, they're a trimester getting ready to deliver, and the stress that the providers have to endure now at 1 or 2 o'clock in the morning, trying to figure out when they had a last hemoglobin A1C, how much information did they have? Did they really make all their prenatal visits? It is a challenge to get on the phone and call these various entities that they can remember. Now, it's hard for people to remember, let alone during the day, but pregnant and at 1 o'clock in the morning in labor pain, they may not always have all of that information. And so we really need to look at a network that we can create with technology that would allow us to be able to exchange information. I think that would be able to give the providers the information that they need in a safe environment that would really allow them to take care of their patients while we're trying to figure this part of the ecosystem out. There has to be, and I agree with you, where we look at where our finances are structurally, and then how do we take the low-hanging fruit that we know that will give us the long-term sustainability and an ecosystem, but we have to start now.
May I add also, and I want to emphasize, because Dr. Green, I think you laid it out. I'd like to add, if we're able to send men and women to the moon, if we're able to do teleconferences across the Atlantic, if we make this a priority, we can do this also. And with COVID, in the midst of a pandemic, we have to do things differently. We have to ensure that everyone has access to telemedicine, and not just say telemedicine or telehealth is available, but do they have access to it? Do they have the ability to use a broadband system? Does their community have access to it? So we can't allow certain things to be available for certain populations, but not available for others. So we're basically shining a light on something that has been in existence for, I would probably say, centuries, but today's a new day and we need to make it a priority. Maternal health is a priority.
Right. And it's not a priority for poor people, because let's remember, when you look at the structural implicit bias, you will find that your economic status or education doesn't necessarily protect you from this, right? But imagine now with the other struggles of issues that you have, it just complicates it even worse. And part of our discussion before, you can't say that in certain zip codes, if people were not going to have access in a certain period of time, that it wouldn't have been an emergency, as it should have been for our communities. And so I think now is an opportunity to really be able to navigate through and put a system in place that allows us to do better because we can.
So I want to thank you, Dr. Green and Dr. Jones. In summary, here's what I heard in terms of next steps. We need implicit bias training. The good thing is that we're talking about it now, but we do need to take it all the way through. I know that all of us have been in some of the most stellar academic institutions and public institutions in this country, myself included. And I do remember the things that I would hear colleagues say that were, it was biased, and it was So we've heard colleagues say these things. So we know that that exists all the way through to the medical students that are being trained right now in certain facilities, right? So we really need to address it at the root, but we need to go all the way to our next generation of physicians, nurses, administrators, physical therapists, ultrasound technology, anybody who can say a negative word to someone when they're trying to seek care. I think we need to do something, and we can do that. There are criteria available. I want you to know that the Blue Cross Blue Shield in their sponsorship for this event has actually given us support to develop an implicit bias training program. And we hope to launch that in the spring of next year. So I want to thank Blue Cross for that support, but I'm going to need all of you all's help in really designing something that is going to be impactful and be culturally competent, sensitive, and real about what providers in the Illinois in our state are dealing with. The next thing is telemedicine. We need to ensure that people have actual access to it. So that means you need to confirm that there is internet access in that community. And if it's not, we need to change that too, guys. It's structural here, but we can come together and we can make a difference and lean in on this and move this forward. The other thing on telemedicine is, though, we have to decide and be as a medical community, when does telemedicine actually make sense and when does it not? So if you're monitoring someone in the 3rd trimester of pregnancy, and guys, I'm an internist here, but let's kind of apply some common sense. And she's at risk for that blood pressure going up. And well, if you're not measuring that accurately at the right intervals and making a move, we're missing the boat. Okay. And I can say that as a mom, with my 2nd pregnancy, where I did have my blood pressure rising. Okay. So it's really important. I was at UFC every 2 weeks getting monitored. Right. And then finally, failing networks, hospital closures, L&D closures. We've got to, as a collective, lean in to solution around this issue. And I think I'm going to try to just take 3 recommendations, guys, that we push forward. And if you're good with those 3, I thank you for coming on today. We're going to take an intentional 15-minute break, come back at 11:31. And the next voice you hear, I will be introducing Commissioner of Chicago Department of Public Health, Dr. Allison Awadi, for 15 minutes, kind of update on Chicago 2025. And Mark Shields, who's a member of the Board of Governors, will moderate a panel on kind of applying the principles of a well-being trust in the context of COVID. If we'd done that, how much of a difference it would have made. We got a great lineup for that panel, including journalist Natalie Moore from WBEZ. She's author of several books. Natalie Moore will be on. So please join us at 11:30. Let's take a break. Thank you, Dr. Green, again. Thank you, Dr. Jones, again, so much, guys. Please come back in 15. Thank you, Terrence. We are ready to get started. Awesome. I believe Dr. Awadi has joined us.
Yes, I'm here.
Hey, how are you?
Good, how are you?
Very good. Well, thanks everyone for coming back. This is our last presentation for our 8th convening of the State of the Health of Chicago for the Institute of Medicine of Chicago. I want to thank all of you guys so far. We've had, honestly, I think great discussions, great chat activity, and great private chats to me and suggestions. So I appreciate that. This upcoming session is being sponsored by the Portis Foundation and the Michael Reese Research and Education Trust that has been supporting the exploration of the feasibility of a well-being trust for Chicago. So I want to thank the Portis Foundation and the Michael Reese Research and Education Trust for their support. We're so pleased today to be joined by our Chicago Commissioner of the Department of Public Health, Dr. Allison Awadi. And Dr. Awadi, I have to say, when I look at your bio, you were trained for such times as this. Dr. Awadi started at the Chicago Department of Public Health in 2015. She was confirmed as the commissioner of the City of Chicago Department of Public Health in January of 2020. So as a chief medical officer, she oversaw disease control, environmental health, emergency preparedness, and behavioral health divisions. She's worked on disease outbreaks, immunization promotion, tuberculosis response, immunization, lead poisoning prevention, substance misuse, Prior to CDPH, Dr. Awadi was at the CDC as an EIS Epidemic Intelligence Service Officer. And in that role, she focused on outbreak response, including international work on Ebola and Middle East respiratory syndrome. So Dr. Awadi, really, gosh, you know, day 2, epidemic breaks out of your being confirmed. So we're really looking forward to talking with you today. We appreciate your educational background. Harvard's been represented today by you and the commissioner. A good bachelor's degree from Harvard, a master's degree in public health from Columbia, and medical school and clinical training at Yale. She's board certified in internal medicine, woohoo, and a pediatrician, and actually continues to see patients, primary care patients weekly. So we're thrilled to have her here today. She's going to kick off probably for the next 10 to 15 minutes, giving us an update on the rollout of Chicago 2025. So we look forward, Commissioner Awadi, to your remarks. You will be followed immediately and to go into a panel on discussion about the principles of a well-being trust. And that panel will be moderated by Dr. Mark Shields, who's a board certified internist, a member of the Board of Governors of the Institute of Medicine, and a senior advisor to Guidehouse Health Consulting. So we're looking forward. Dr. Awadi, and then we'll hand it off to Mark and the panel. Dr. Awadi, welcome.
Thank you so much for having me. We're working a little bit on the internet connection, so I hope everything stays stable here. But yeah, really appreciate the invitation. And as you know, outbreaks are what I have worked on my whole life, but what's been really different about this one is doing it right here in Chicago at this level. And what I'll be going over today, just at a high level, is our Healthy Chicago 2025 plan. And I want to just start with making the point that we'd done a lot of emergency preparedness in terms of stockpiling for COVID and thinking about emergency response. But in a lot of ways, the work that went into building our Healthy Chicago 2025 plan also set us up, I think, to have a particular lens thinking about racial health equity in our response here. So let me just share my screen and make sure people are able to see it. Are we good? Excellent. Okay, so the focus of Healthy Chicago 2025 is on closing our life expectancy gap. And we do start, make sure this is in a, make sure this is in a format where everybody can see the whole slide. There we go. Okay, so first of all, where we just start from COVID, because at this point, every conversation starts with COVID. First, we have disproportionately seen COVID case counts for deaths on the left and for cases on the right. And you can see in purple are Black non-Latinx Chicagoans who very early on had a really big surge of deaths in particular. And still, as you can see, 42% of the deaths here in Chicago have been among Black non-Latinx Chicagoans, where that's only 30% of our population. Whereas cases, blue, represent Latinx Chicagoans. You can see we saw a later surge in cases and have very disproportionately seen cases, 48% of our total cases among Latinx Chicagoans, and that's where only 29% of Chicago's population is Latinx. And so we think about, why is that? And every time we have an outbreak, people start to think about what are the ways in which this outbreak is bringing to light all of the cracks, all of the gaps, all of the inequities that exist in our society, because outbreaks always look for opportunities where people don't have equal access and equal opportunity. And COVID here, I think, has really brought this more into the light. We also, as we think about learning from COVID, have seen what an amazing opportunity it is where all of Chicago comes together around a particular response. These happen to be pictures related to food distribution, but I could have chosen a whole range in which we have just seen people from the healthcare sector, from the philanthropic sector, from the community-based organizations, from everyday neighbors, from churches and other religious organizations, stepping up in all kinds of ways to meet the needs of our neighbors. And I think we've learned a lot about how we can do that more effectively to make sure we're all rowing together when there are major things that hit our city. And we'll want to kind of learn from that idea of making sure that as we're all doing good work for each other, that it's well coordinated. The other thing is that we really have the opportunity here to learn from the call for racial justice that has also come out of this summer. We do not think it's by accident that this has risen sort of at the same time as COVID. It's pretty common where you're having an outbreak and a lot of disruption in society to see real calls for change that are based not just in the disease, but in other ways in which our society is not fair. And in this case, obviously, has a very long history of disproportionate death, particularly for African Americans in terms of interaction with police. And so I wanted to just very quickly in 1 minute play this clip, if it will play.
America is dealing with two viruses, one being COVID-19, and the other is COVID-16-19. One virus, we have specialists, epidemiologists, virologists, who understand what we need to do. But unfortunately, with the older virus, America has ignored the cries, the pain, and the anguish that has come from the lips and the lives and the hearts of many people of color in this nation. We are not all responsible for some of the actions taken yesterday, but as a city, we are all accountable. We are all accountable to build a city and to build a nation, a yet to be United States of America.
So that was Reverend Moss, who I imagine many of you know, who's been such a strong voice on this. This was immediately, after the death of George Floyd, and then the civil unrest and the looting that followed. And I think we've been trying to think together, sort of as a city, and I think it's important for all of us as we think about COVID response to think about this call together. And so with health,
America is dealing with two.
So first of all, some very quick facts. Life expectancy is actually decreasing in Chicago overall. Where we look at the difference between 2012 and 2017, for the first time, like in this century, we saw life expectancy drop as a city. But when we break that down, we see that, in fact, for white non-Latinx Chicagoans, we continue to see a very small increase in life expectancy from 79.8 to 80.2 years. Whereas in contrast, for all other race and ethnic groups, over just that 5-year span, among Asian non-Latinx, we saw a drop. Among Latinx, we saw a drop, and for the first time, life expectancy below white life expectancy. But the major difference here is what Black non-Latinx life expectancy is here in Chicago. 72.6 years, and then a drop over that time to 71.4 years. An 8.8 year gap between Black Chicagoans and other Chicagoans in terms of life expectancy. Unacceptable, preventable, and something we need to work together on as a city. The top 5 drivers of this life expectancy gap, the biggest one is chronic disease, 4.3 years. And so where we think about the disproportionate impact on mortality that COVID has had, and you think about, we've all learned the underlying where people have diabetes and lung disease and heart disease, that predisposes folks to have more severe outcomes and in fact deaths from COVID. This is part of that story. Following that is gun-related homicide, infant mortality, HIV and other infectious diseases, and opioid overdose. And so these 5 proximal causes are the particular focus of the health department over the next 5 years in conjunction with partners. Those of you who have been right along with us, Healthy Chicago 2.0, which was our 5-year plan from 2016 to 2020, was where we started calling out health equity in particular. And with the next version of this, which is 2025, we really are more explicitly talking about racial life expectancy gap and getting even more specific. we work with something called the Partnership for Healthy Chicago. It's more than 40 members that advance health and racial equity, as you can see, from a wide variety of sectors. And we did a full community health assessment with thousands of surveys, dozens and dozens of focus groups, collected a lot of data. You can go online to learn more about it. But we ended up really wanting to talk more explicitly about root causes here. So where we're thinking about putting this in a positive light and wanting increased life expectancy for Chicago, a blossoming tree, we think about turning those same drivers of the life expectancy gap into positive framing, thinking about having less chronic disease, improved mental health, ending the HIV epidemic, having communities that are violence-free, healthy parents and babies, and communities that are drug-free. Where we think about how we get there, you have to focus on sort of the trunks and the branches, where this is clean air and vibrant neighborhoods, health and social services, housing, food access, and public safety. But then when we think about what's driving those, it's where you get into social and institutional equities, where instead of, we're again trying to put this in a positive light, we want anti-racist and multicultural organizations. We want public accountability, fair laws and regulations, economic opportunity for all. And the idea is to in conversation with a lot of folks from around Chicago, think of this as how we work toward where there are inequities now in a very positive approach, recognizing they're there, but also recognizing that where we have equitable access to resources, environments, and opportunities, where we have community power and freedom from oppression, we can have increased life expectancy. And so just at a high level, the assessment themes and the primary goals are four: to close the racial life expectancy gap as a city. We'll be working to improve systems of care for the populations most affected by the inequities, to further health and vibrancy of neighborhoods, to strengthen community capacity and youth leadership, and transform policies and processes to foster anti-racist multicultural systems. It gets more specific as you dive into the plan. These are the priority areas: housing, food access, environment, public safety, neighborhood planning and development, health and human services, and then our public health systems and organizations. And there are very particular focuses driven by the data for each of these areas in terms of where the focus is. We have an ideal state, which we know is just an ideal, but we did feel it was important to start, and this was done in partnership, to say that, the goal would be that within one generation, all Chicagoans could have a healthy, affordable home, could have enough nutritious food, and that local food businesses could thrive, could be breathing clean air free of harmful pollutants, would be safe across the city with trusting relationships with law enforcement, be living in vibrant neighborhoods that reflect their identities, benefit from a full range of health and human services, and have voice and power in the public health system. We have a long way to go to get there, but stating this collectively was important. And so the 2025 vision is imagining, again, in a city where all people and all communities have power, are free from oppression, and are strengthened by equitable access, as we've laid out. These are the guiding principles that we've used. As you can see, the asset-based, for example, the equity-focused, the trauma-informed, specifically calling out anti-racism, thinking about building capital, and community-led. And at the health department, there are a lot of detailed ways that we're working on this. In the HIV and infectious disease space, there's getting to zero. There's the work that we've been doing to move contact tracing into communities. In chronic disease, there's examples like walkability assessments. In behavioral health, there's lots of investments in terms of increasing mental health access, or bringing more of a data lens to where we're seeing opioid overdoses surge. In maternal and infant health, our Family Connects program is trying to make sure that the connection after babies are born is followed up at home for in-home nurse visits. We're also thinking about our own internal transformation. We have a chief racial equity officer at CDPH really looking at all of the ways internally we do everything from hiring to contracting to pushing resources out across Chicago, and very excited about the work that's happening there. To give you one concrete example, in the food access space, where we're thinking again about addressing these inequities. Some of the more specifics here are we're at work working to publish a food environment map. We're establishing a food policy initiative, an advisory group to advance food equity, and then strengthening food policy plans, practices, food safety net, et cetera. Although the Chicago Department of Public Health is in the planning of this, this is meant to be an all Chicago plan. And the idea is that where organizations, whoever they are working toward better public health and these root causes, we are doing it in conjunction with each other. We'll be setting up an equity dashboard following a number of these indicators. I invite any of you who have interest in this to join the conversation. And we have a lot more online about how, depending exactly what your role is, some of the specific things that you can be doing toward the Healthy Chicago 2025 vision. This is, of course, just the very high level overview, and there are people, hundreds and hundreds of people hard at work of the details of turning this into a reality. But I appreciate some time just to frame what we are trying to think about at the health department with our partners and with all of you as we hopefully lead toward a healthier Chicago. And I'm happy to take questions. Thank you.
Dr. Shields. Thank you, Dr. Awadi.
Dr. Shields, you're muted, so we can't hear you.
There you go.
There you go. We got it.
There you go. Thank you, Doc.
Okay. All right. And technology.
We can hear you.
Okay. Well, thank you so much, Dr. Awadi. And I'm going to try to bring up these slides. The Institute of Medicine of Chicago has had a long interest in the disparities of health outcomes. And over the last 2 years, we've really moved our focus to be on the social determinants of health.
Yep.
And I'm having a little trouble with these slides. There you go. Okay. As we've moved to the social determinants of health, has been discussed by multiple speakers today. There is, as we know, this major health equity gap between white population and minority populations, not only in Chicago, but also nationwide. And our real challenge in this panel discussion is, what can we do about this? We're not just observing it, but what can we do? And it's these underlying social determinants of health that IOMC has been focused on: the loss of health insurance, crowded housing, multi-generational housing, racism, reduced ability to work from home. And we could go on in terms of those underlying causes that have really driven this difference in outcomes for COVID deaths and morbidity. Next slide. Next slide. Next slide. What we have discovered as IOMC has done this research is that there is a great promise in well-being trust to attack the social determinants of health. As we've looked nationwide, these trusts can have varied focus, varied communities that they serve, a varied organizational structure, but they all coordinate and integrate services. They reduce duplication and increase efficiency. They provide infrastructure and technological resources. They add value by staff training and operational support. They encourage blending and braiding of funding streams, and they engender a shared purpose across multi-stakeholders. Next slide. To do this assessment of feasibility, IOMC put together 4 subcommittees under the leadership of the Management and Implementation Committee. The first looked at trusts nationwide. The second looked at coalitions and alliances in the Chicago metropolitan area. The next looked at metrics and analytics. Those excellent sources of data. Dr. Awadi talked about a number of them, but then also some additional sources of information that could help drive change for social determinants. And then glossary committee. We looked to national and regional experts, interviewed them, and had significant input. Next slide. This was an in-depth review with literature, interviews, reviewing documents, and data. Next slide. This subcommittee was led by Pankaj Patel and looked at the national trust scene across the country. There are over 100 well-being trusts and accountable communities for health across the US. Most of these are at the state and regional level, with a few at the metropolitan level. And they're funded different ways, some through endowments, others taxes, or progressive blending and braiding of funding streams. Next slide. Then we looked at local coalitions and alliances, and this was led by Cheryl Ermiter and Bill Friestad. And we found that there were over 40 organizations that had coalition or alliance in their name or in their mission in metropolitan Chicago that addressed aspects of social determinants, equity, and drivers of well-being. There was significant variation in the size of these and in their scope and activities. There were many bright spots, and actually we've talked about a number of them this morning. And some of these organizations are growing, and others, as a reflection of the impact of COVID, were really not available in the spring and summer. But we found that there were actually few broad multi-sector collaborations, and many of these alliances, coalitions struggled for sustained funding. Next slide. The Metrics and Analytics Committee really grappled with what could we do to have an up-to-date monitoring system to know how each neighborhood is doing. And so this group looked at the Chicago Health Atlas, some of the wonderful work by Dr. Awadi and others, as well as looking at the well-being in the nation data. But then we also looked at some new additional opportunities that could give us real-time feedback or very close to real-time, such as linking referrals to social service agencies and then the return information, and do that across providers, across agencies, and other opportunities. Next slide. And then we had a glossary committee that looked for the definitions of keywords and concepts so that everyone was talking on the same language. Next slide. And the preceding slides, as well as the next several, have been put together by Elizabeth Carlson, who's the chair of our implementation committee. And she has been sharing this work with her 2 co-chairs, Denise Giambalva and Pankaj Patel. Next slide. These are the 7 common principles of successful well-being trusts that we've extracted from this research that IOMC has done. That these organizations have collaborative platform. They have a common vision and shared agenda. They collect and share data with common definitions for continuous learning. Local communities are central to determining the priorities and initiatives. That there is a broad stakeholder representation. There are pooled resources for sustained funding and an ability to scale programs. Next slide. So a common platform was common to these. There's a backbone support to be able to pull the multi-stakeholders together. Next slide. Next slide. That there's a common vision and shared agenda for the organization, and as they work on common projects, people are all pulling together. Next slide. There's a collection and sharing of data for continuous learning. There's common definitions, there's shared definitions of the data points. So there really can be comparisons across organizations in finding best practices. Next slide. Local communities are central to determining the priorities and initiatives. It's really a bottom-up decision-making when selecting the priority for a community or the initiative, not a top-down process. Next slide. There's a broad multi-stakeholder representatives. The most successful trusts have certainly local community organizations, but then also healthcare providers, healthcare payers, foundations, interested businesses, governmental agencies, and others. So that multi-stakeholder is critical to success. Next slide. There's pooled resources for sustained funding, and typically there's blending and braiding of the funding sources. So they're all focused on some common initiatives. And next slide. There's ability, once best practices have been identified, to be able to spread the program across a metro area or a state. Next slide. So those are the common principles of a well-being trust. And really, the question is, what would the results be if these common principles were applied universally? And that's going to be a question for the panel. If we had these principles consistently applied, how could it assist in our work on COVID? Next slide. So these are the 7 principles. Next slide. Next slide. Next slide, yep. And for more information, you can go to the IOMC website. Next slide. I'm really delighted to be joined on this panel. Thank you so much, Dr. Arwady, for your comments, and Cheryl has introduced you. Let me introduce the other 2 panelists. Dr. Marshall Chin, who is a Richard Perillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. He's a general internist with extensive experience improving the care of vulnerable patients with chronic disease. He is also a fellow of the Institute of Medicine of Chicago. He is the co-director of the Robert Wood Johnson Foundation, Advancing Health Equity. He also chairs the National Quality Forum Disparities Standing Committee that recommended how to achieve health equity through performance measurement and payment reform to the Centers for Medicare and Medicaid Services. Welcome, Dr. Chin. Our next panelist is Natalie Moore. She is a reporter on race, class, and communities at WBEZ, where she covers segregation and inequality. Her enterprise reporting has tackled race, housing, economic development, food injustice, and violence. Natalie's work has been broadcast on the BBC, Marketplace, and NPR's Morning Edition, All Things Considered, and Weekend Edition. She's the author of The South Side, A Portrait of Chicago and American Segregation. This was the winner of the 2016 Chicago Review of Books Award for nonfiction and a BuzzFeed Best Nonfiction Book of 2016. It's really an honor to be on this panel today. I'm going to throw out the first question to you. Actually, I'm going to just ask your permission. I'm going to use first names. So Allison, Marshall, and Natalie, I hope that's okay. Please call me Mark. Allison, I'm going to pose the first question to you, and this is actually the same question that I'm going to ask all the panelists. Have these principles that I've just gone through about a well-being trust been used consistently across the Chicago metro area since the outbreak of COVID to address the equity gap from COVID? Oh, you're muted, Allison. Yeah, okay.
There you go. Can you hear me?
Yep, now I can hear you. Great.
Yeah, so certainly we have tried very hard to use exactly these kinds of principles in our response. I think where we're moving really fast, it becomes more important than ever to actually make sure that the voices, of folks within communities in particular are sort of, leading in this decision making. Often when things speed up, there can be a tendency to want to just sort of pull in and stick with the folks But we have learned, it's clear not just as a principle, but in practice, that if we are going to beat this thing, it is about making sure that there are partners who share the same concerns and approaches and are willing to help lead and direct in terms of what needs are in different communities and pull it out of just the what do we need right this minute to that larger conversation. And so I think just to put a really concrete example on that, where we think about testing access, the health department normally does no testing of any kind. It's all done in the clinical space. But we saw really early on that there were real problems in terms of, we saw people who had very good healthcare access getting a lot more testing. We saw, particularly on the south and west sides where COVID was surging, less access to testing. And so worked sort of in a data-driven way, in a resource-driven way with some federal funds to say, okay, we're going to stand up testing and we'll make the data available week over week. Where does it most need to go? But then we don't actually make the decisions at the health department about exactly where should that testing be. Is it best, with this organization at this church? That's through the Race Equity Rapid Response Team, which was stood up really from the very beginning when we started really talking about what that early data was looking like. The mayor really wanted to make sure that we were grounding, not just talking about this problem, but grounding it in action and grounding it in a way that that the actual decision-making and resources are done in collaboration with a wide range of stakeholders who often have a wide range of opinions. I think it's made us a much stronger response as a result. And we've really sort of built on those initial testing and outreach conversations and used them to drive, for example, where we fund the organizations that are doing our community-based contact tracing, to think about how, again, we build on strengths within existing networks, within existing neighborhoods. And then at the same time, recognize that where we are putting these resources, they are on top of just decades of inequity. And you can't, I think, talk about the immediate needs without also in a longer term way investing. And this is where this fits into the city's Invest Southwest approaches and some of the other larger things that are happening, not just at the city, but with philanthropy to try to work on the decades of inequitable investment that have led to these differences. So we're trying to use these principles really every day and trying to think about how the COVID response can actually lead to change in a long-term way. So if I'm hiring, through a community-based organization, a contact tracer, that's good for a job for a year and a half. But if I can also make sure that there's a learn as you earn component, which we're doing through city colleges, these same folks are getting training that they can hopefully become community health workers and work with FQHC, federally qualified health centers, and be sort of more of a healthy Chicago core in the neighborhoods where we most want to be, to work on that life expectancy gap, to work on that chronic disease part as we build up healthcare access. So taking the COVID, taking these principles and trying to think about what do we need right now today and how does this lead us to a stronger, more equitable Chicago in the long term.
Great, thank you. Thank you. Marshall, I'm going to ask you, given your strong background in chronic disease, particularly, would a multi-stakeholder coalition following these principles have helped us avoid some of the equity gap coming from COVID due to chronic disease?
Well, they would help, Mark. And certainly the principles are aspirational, they're inspirational, they're a great North Star. But where the rubber hits the road is then concrete action and concrete steps to operationalize abstract concepts. And here's where I think we can do better in terms of our intentionality. Just what Allison said, that when it comes down to it, whether I'm a clinician, I'm taking care of my patients and what I do for that individual patient, or from Allison, taking care of the whole city, is what our concrete actions are as people and as institutions. And let me explain like 3 different areas. One is mission. And so ideally, the mission is that we're improving health for all of Chicago, advancing health equity, no matter who you are. And regardless of whether we're a community member, a health organization, whether we're a CEO or whether we're the front line, we would all consistently have that message. It's important both in terms of operationalizing our daily actions, as well as for the advocacy and political support for the types of changes that will be required to do this successfully. So mission. Number 2 would be the root cause analysis. And I love that slide you had, Allison, of the tree and the root cause analysis of what is driving the disparities and areas where there are not great outcomes for some of our folks here in Chicago. And it requires then the deep dive is both for the whole city, but then individual communities, individual health organizations, individual practices. This root cause analysis has to happen at each of these different levels to determine the concrete individual and structural social drivers and medical factors impacting outcomes. The third would be within what I would call then the matching of the solutions and the interventions to address those particular structural drivers. And so, for example, if in my community there is a mistrust issue or there is a food insecurity issue, how do I tailor then my addressing of that particular food insecurity trust issue in my particular practice or my particular community? And then I'll add to that too, critical I think that we should talk about too is really the payment streams, and that ultimately it's not going to be sustainable, or else not going to be able to incentivize and support everyone unless the payment policy follows the goal then of addressing these drivers. It's both blending and braiding care, payment, as you said, Mark, but it's also then some of the more fundamental change to align the incentives. So it's in everyone's interest to do the right thing. And so people want to do the right thing, but they need to be supported so that they can have the business case to be able to address these fundamental underlying medical and social and structural drivers of health.
Okay. Thank you very much, Marshall. Natalie, you and your colleagues at WBEZ have a wonderful perspective across the whole metropolitan Chicago area. And I'm very interested in your perceptions of how these principles have really been followed or have opportunities for improvement so far in our effort in COVID and its impact on the health equity gap.
Yeah, good afternoon, everyone. Thanks so much for having me. Feel a little bit out of my league with all the medical experts here. So please note that I'm coming just as a journalist, as an observer, and not someone who's making policy. I quoted some months ago, Reverend Moss saying, "We're living in COVID 1619. And I think no matter what the laudable goals are, you have to keep it in context that no principles are going to reverse decades or even centuries. But if we're just talking about Chicago, 100 years of really terrible housing policies and economic policies that have kept our city segregated. And that goes to the root cause. So you can do, this isn't to minimize the principles, but also understanding that they alone can't fix everything. I will say, I put a link in the chat that my colleagues and I spent many months on, and we looked at the zip codes with the highest number of COVID deaths and cases and the lowest. So the zip code 60649, which is mostly South Shore, 60623, Little Village. And then the lowest ones were 60610 and 60611, so near Northside and Streeterville area. And so we, it was confirmation of things that we intrinsically already know about life expectancy and the health disparities, but it was also really important to tell the stories of these individuals, because this can sound very statistic heavy, and we have to remember the toll that this takes on the communities. And we contacted 50 relatives of people who died of COVID, and then George Floyd happened in the middle of that. So it was necessary but very emotional reporting, where often my colleagues and I would get off the Zoom calls with families and cry ourselves as people cried on the phone with us. And we heard multiple times, "Thank you for telling my loved one's story," because I felt like he or she was just a statistic. So I just want to elevate that, even when we're talking about these things. When we look long term, I think what has to be kept in mind is just not looking at Chicago or talking about Chicago only as a city, and remembering, so if things start to revert, if we look at the numbers and don't aggregate them, we're missing out on what's happening in places like a South Shore or a Little Village. And the city does have the rapid racial response teams. The city was out front early talking about the racial disparities, but people in Little Village, for example, are still working jobs that require them that they're essential workers. They're still living in apartments where there may be only one bathroom. And so I wonder how, and that's not going to be changed by any of the principles. So what can be done to have them maybe recover someplace else? What are some creative ways to think about how to do triage in these communities in the short term, while also addressing the structural inequities, particularly around housing and employment in these communities?
Okay, thank you very much. Looking forward, Allison, I wanted to ask you, you've had the Partnership for Healthy Chicago, and I'd like to ask, could these principles help you make that partnership even more effective, or help pull in additional members of that partnership as you build a coalition? And I guess I'll also share one of the thoughts that we've heard as we've been doing our research over the last year and a half, is that kind of given the culture of Chicago, that having these partnerships led by the private sector is a key part of getting their buy-in from business and foundations and others. It's kind of, how do you get that buy-in going forward?
Yeah, so I think in this space, we are very much, the reason that we stuck with this Healthy Chicago language, right, is that I think we're in our 11th year at this point of sort of using Healthy Chicago. We started with Healthy Chicago, which was for the first time just pulling together sort of statistics across Chicago and starting to kind of think about things and how are we following them and getting dashboards together. And that was more than 10 years ago. And then with Healthy Chicago 2.0, which was that sort of 2015 to 2020, that's when, like I said, we started really, the focus became health equity. And it was about, we are going to, like, I don't care if the whole city is getting better on something. I mean, I care, but how we're going to define success is whether whatever the group that is furthest outlying is moving closer to where it should be. And so we had, 250 indicators, and it was everything from, maternal mortality to things like smoking. And there were different, LGBTQ youth turn out to be the focus for one particular area, and a particular neighborhood may be a focus here. Uninsured, it was young Latino men between 25 and 35, and tried to get much more specific about who are we pushing resources in toward this goal? And so with Healthy Chicago 2025, we want to really continue to build on, I think, what was very successful with Healthy Chicago. We've got those kind of 40, 50 key partners. We actually had about 600 people regularly sort of involved in the different working groups and the different kind of individual organizations toward like these pretty specific goals. And even thinking, you know, to your point around business community, philanthropy, et cetera, trying to carve very specific spaces so that, you know, if there is grant making happening, like, let's use this same language. Let's think about this in the same way. If you are a business, like, here are the very particular pieces. And I think what we're thinking about a little bit with 2025 is how we, you know, we're wanting to turn a little bit of that on its head in terms of making sure there's additional sort of community leadership, whatever that means in these different spaces to your principles. But I very much, the thing I liked about Healthy Chicago, like if you look at either 2.0 or 2025, it doesn't say this is the Chicago Department of Public Health's plan. It says this is the City of Chicago's plan. And we very much want partners in all of the spaces to own this as much as the health department does. I think we do play, particularly in the healthcare system, we can play a fairly important neutral coordinating role in some ways, but we're not as strong in, you know, with the business and philanthropy. And this is where, at least within the city, big C, City of Chicago level, we've done a lot more work this time around to say sort of, you know, housing and, you know, planning and development and some of these other sections that are more engaged with the sectors there. Can you help be just a coordinating voice and let, you know, this will work best when, you know, businesses, to your point, see this as something that they're reflected in. So, you know, if people, if anyone is not connected to this and would like to in your individual, in your professional roles, I'll put in the chat box how you can get connected, because we, you know, I plan to continue to sort of be nimble in terms of thinking about what this framework looks like. And it is, like I said right at the beginning, it's about rowing together as a city, and having these principles is an important place to start. You got to make sure everyone's coming at it from a recognition this isn't all what are we doing today. It's this long-standing inequities, and that, you know, as Natalie was saying, that need long-standing investment. So I'll put the stuff in the box, but thank you.
Okay, thank you. Marshall, as we go forward, you know, with next steps with COVID, we have immunization on the horizon. What other, how can we use these principles to improve our efforts to close the health equity gap going forward?
They were both like issues having to do with like overall culture and mission, and then very concrete steps. And so many of you probably saw yesterday's debate. And one of my favorite questions was when Kirsten Welker asked the candidates to look in the camera and say what they would say to African-American parents who are about to give their child the talk. And I would say that in some ways, we have the analogous situation of having to have the discussion regarding racism as individuals as well as within our organizations. I mean, it was heartening to see, Alison, your slide about those efforts inwardly at Chicago Department of Public Health, which takes a lot of courage, because essentially all of us in every organization has these baked in structural elements of racism. And it's a hard discussion to have and a hard inward look. And so to the degree that we can have these honest, difficult, and at times painful discussions, the more we're going to be able to design the interventions that will get at some of these root structural issues. So part of it's the culture. Some of these concrete steps. I fairly recently wrote an article with a provocative title, "What if the role of healthcare was to maximize health?" Because part of what we do in healthcare is to work on health, but partly what we do is not aligned to do what would maximize the health of the people of Chicago. I mean, in general, we underemphasize preventive care, public health, primary care. And if we truly had an aligned mission that the goal was to improve the health of all Chicago folks, there's a lot of institutions, a lot of organizations that would change what they're doing. So it requires us, again, to think, do that root cause analysis. What do we need to do to truly improve health for diverse populations across the Chicago city? And then how can we create the systems, the baked-in systems of delivering care and the payment streams that allow people to do the right thing? So why don't, for example, we incentivize those organizations that reduce healthcare disparities in the city or that promote public health? I mean, we don't do that nearly enough, virtually at all, in the way we design our payment systems, for example. So we need to have this alignment across all the different sectors to really do that North Star that's embodied in the principles.
Great. Natalie, how could multi-stakeholders work better with the press, the media, to advance work on the equity gap?
Well, selfishly, I would say tell your hospitals to talk to reporters, even if it means that they might not be in the best light. For our project, the only hospital we focused on 4 hospitals that were serving the communities, and only St. Anthony would talk to us. Northwestern would not. And, we understand that a research hospital is not the same as Jackson Park, but how do you share resources? Hospital transfers have been an issue. PPE's been an issue. How much government aid is given to one hospital versus another? Jackson Park and South Shore hospitals just ignored. I did talk to a Jackson Park nurse who had issues with PPE. So I would say talk to us. I did interview Dr. Chin's colleague, Monica Peak, about racial health disparities. And, she's been a great resource, even talking on background. If you want to be a whistleblower, we won't use your name if you want to share information that you think is detrimental or not helping patients. But, sunshine is the best disinfectant.
Okay. Well, thank you, Natalie. I really want to thank the whole panel for this. It's time for me to turn this over back to Cheryl Whitaker for our closing remarks. It's really been very helpful. This has been very insightful to IOMC as we've thought about social determinants and the health equity gap. And your comments will help guide us on our next steps. So thank you very much. So Cheryl, turn it back to you.
Well, thanks, Mark. Before your panelists go, are there any questions from the chat? I'm just taking a look. Marshall posted an article on practical lessons for teaching about race and racism, leading frank discussions. Allison posted a link to Healthy Chicago 2025. Does anyone have any questions or comments, thoughts? Natalie also posted the story, the 50 stories, the 50 lives and 50 stories. So thank you for that. If I see any questions in the chat, I'll come back to them. I want to thank all of our panelists for their just extraordinary input here today. I hope that you'll agree for a first time out for the Institute of Medicine of Chicago that we did an okay job kind of pulling all of this together in this environment and seeking to use this, the technology that we had access to. So I want to thank our panelists. By name, I want to thank Dr. Ezike, who came on early morning to review kind of the state of COVID and COVID-19 in Illinois. She actually did just a candid sort of fireside chat with us. And that was really extraordinary to be close to her and her thinking and her experience of walking into a pandemic as a new health commissioner. We had a great conversation about immunization strategy in COVID-19, kind of what do we know, where do we go from here. I want to thank our sponsor for the opening plenary was the Hectone Institute. I want to thank Dr. George Janea for his sponsorship and for the Hectone sponsorship of that session. I want to thank the Portis Foundation for their sponsorship of the immunization strategy session. We had Dr. Gayle, who co-chaired the National Academy of Medicine work group on equitable distribution of a vaccine. That link is on our website and is on LinkedIn. We provided that to you. And we also provided the state's draft response, really kind of to our equitable distribution and really sort of common sense distribution of the vaccine that attempts to kind of quell the vaccine in its tracks as we have access to it. We had Donna Thompson, CEO of Access Community Health Network, one of our federally qualified health centers. And I just want to say that we have the federally qualified health centers today represented on almost every panel. They're on the front line of healthcare, particularly for people who have Medicaid or who are uninsured. So we thank Samantha Olds-Frey from the Illinois Association of Medicaid Health Plans. And Samantha made a very good observation that we should include in our response, a kind of formal response, and sort of we coalesce all the results of today's feedback of today's sessions, is that they need access to the state's immunization registry, not person by person, but by population, by zip codes, by towns, so that they are able, that the health plans, and there are, Blue Cross Blue Shield, Centene, Meridian, Molina, Aetna, Illini Care, and Cook County Health Plan, that they are able to make interventions that make sense and that are timely and relevant by looking at the data from populations in an area. So if one zip code has a lot of people getting vaccinated and the other one doesn't, it helps them to target population health strategies and partner appropriately to do that. So I want to thank Samantha for coming on. The next session was sponsored by the Michael Reese Research and Education Foundation about the importance of integrated care in the COVID-19 environment. And we thank Raul Garza, Vice Chair of the Institute of Medicine Board of Governors and President and CEO at Martha's for putting that one together with Dr. Miller and Dr. Ramandar. We talked a lot about the importance of integrated care, mental health, substance abuse prevention and treatment, and including children and teens as a part of the conversation. So that was very important. We then talked about maternal morbidity and mortality in the context of COVID, but also pre-COVID with Dr. Jones from Rush and Dr. Green from the Family Christian Health Center. A couple of really important points came out there: failing networks, closing hospitals, abruptly closure of L&D facilities, lack of access to appropriate sort of screening, ultrasounds and other necessary tests for women who are deemed needy, implicit bias training and the need for it, and then telehealth, access to and appropriate use of telehealth. So in our final panel, you were here for it. Thank you so much for staying on. Thank you, Dr. Shields, for putting this panel together, and thanking Dr. Awadi as our Commissioner of City of Chicago for walking us through Chicago 2025 and participating in the conversation on, how principles of well-being trust, if they were applied, what difference would it make? We thank Natalie Moore from WBEZ. Congratulations on publishing her book and several books. We thank her for her work going deeper into COVID-19 stories. And we thank Dr. Chen for kind of walking us through some of the responses from an academic perspective and sharing the article with us. So yeah, it's been a good day, guys. There's so much work to be done. I think one of our key follow-ups is putting together this kind of letter of response that we will send out to the Illinois Department of Public Health, to the Medicaid agency, which again takes care of finances healthcare for 25% of Illinoisans. So it's an important place to kind of give feedback to. And so if you have any thoughts, please send them to us. You can, find out how to, and please follow us on LinkedIn. We're trying to stay active there and keep you informed about what we're doing. Thanks, everybody.